They can interact amongst themselves also. Huh?
Yeah.
They can interact amongst themselves also.
Yeah. They can.
Yeah.
Only they are supposed to unmute and dance.
Yeah.
Yeah.
We are starting in a minute from now.
Professor Tanna has come. Good evening, Dr. Tanna, sir. Good evening, sir.
Tanna, sir, good evening.
Yes, to unmute.
Number 10, right? Okay.
Yeah, please. Please mute your. I'll mute.
Raju sir ಹೇಳ್ಬಿಡಿ ಸ್ಟಾರ್ಟ್ ಮಾಡಿ. Can you hear me? ನಾ ಮಾತಾಡ್ತಿದ್ದೀನಿ. ಅವ್ರು ಕೇಳಿಸತ್ತೆ ಕೇಳಿ.
Hi, Professor HOLZ.
Good morning, good afternoon, and good evening, friends. I welcome all of you to the Masterclass on Proximal and Tibial Fractures. I am Dr. Madan Balal, President, Bangalore Orthopaedic Society. We are fortunate to have outstanding lineup of speakers today from all over the world. We have Dr. Paul TORNETTA, Dr. James STANNARD, Dr. HOLZ, Dr. TANNA, Dr. John MUKHOPADHYAYA, Dr. AJIT KUMAR, who have a lot of experience and need no introduction. I would like to sincerely thank each of them for taking out their time from their busy schedule and agreeing to be a part of this webinar. The achievements of each of the speakers, which goes on into pages, has been circulated among the members. I'm also grateful to moderators, Dr. Rajiv Naik sir, Dr. Uday Kumar sir, and Dr. Reddy sir, for not only designing this webinar, but also putting in their efforts to bring together this distinguished panel of masters. I'm sure each one of us is going to benefit from each of these talks in our day-to-day practice. I would like to thank all the members for joining us and being a part of this webinar. Dr. Uday sir, you can take over.
So unmute karo.
Keep it there. Keep it there. Unmute karo. I have to mute this thing. Sir, you can talk.
किधर है? Unmute की सुनाई नहीं देता.
No, we are this thing. Can we start? Start. Yeah. Please start, sir.
Professor HOLZ, can you hear us? Professor HOLZ, can you hear us?
No. He has to unmute himself.
Professor, you're on mute.
Yeah. You have to unmute yourself.
Do you hear me?
Yeah. Now we can.
Okay.
Sir, we invite you to start the seminar with your first topic.
Okay.
Everybody else, mute your lines, please, so we don't get feedback.
And your topic is evaluation and planning tibial plateau fractures.
Yeah.
Please share your screen, sir.
Full screen.
Yes.
You can see?
Not yet, sir. Not yet.
What?
We have not yet seen your screen.
Why not?
There is a button
in the bottom. There is a green area with an arrow which you need to press to share your screen.
This one.
Yeah, at the bottom. Yeah, that's good. Yeah.
Yeah.
And you should have your presentation open before you do that. Yeah, that's great. Yeah. So now maximize it and you'll be fine.
Go to presentation. If you go to the slideshow and then say play show, that will show.
Now you can see?
We can see, but if you do slideshow, play show, or go to the podium, little podium symbol, it'll play like a slideshow rather than outline form.
or go to the bottom and press that bigger square right at the bottom. Bottom right, there's a few. So this is still on the.
Not good.
You have to put it on the full play mode, yeah?
Full screen.
Yeah, so if you go to the bottom right, there's a sort of square box. There are a few boxes and a square box at the right. Yeah.
In the slideshow.
Yes.
Yeah, that's better. Yeah, that's great.
That's now full.
Got it. Yeah, now that's good.
Okay. So evaluation and planning tibial plateau fractures is a very responsible task because a lot of tibial plateau fractures are very complex, and they are always accompanied by injuries to the ligaments, to the menisci, and to the soft tissues. These, especially the soft tissue injury, is very crucial in determining the time of embarking in reconstruction procedures. I show you here a case from very old days, 1964. This was done by one of the masters of AO, Martin Allgöwer. It was a complex fracture. And 30 years later, this patient dropped in Stuttgart in my practice with a severe arthritis. In those days, they tried to reconstruct the plateau as good as possible. But in those days, our ideas of approaches, our ideas of the complexity of the surface of such a plateau fracture were not yet developed in that way as it should be, because the cartilage damage and the incongruity basically determine the fate of the joint. Additional injuries like meniscal injuries, vascular injuries, and so also are responsible for the outcome. Nowadays, with modern radiology, we can really picture and find out exactly each fragment, whether it is anterior, posterior, lateral, medial, and so on. And with this modern knowledge and modern diagnostics, we have overcome the simple classifications of those days in the 60s, hole and look. Later on, it was the classification from Canada, and then T.M. Moore with the classification of ligaments as well. So nowadays we really can make visible all incongruities very well, and accordingly we can plan our surgery. The evaluation is what is this? The evaluation starts with an information about the injury, valgus, varus, axial, high or low energy. Then most important is the soft tissues, open or closed, and a compartment syndrome, which often accompanies a bicondylar tibial condylar fractures. The pattern of the injury is nowadays routinely determined by X-rays and a CT. Sometimes an MRI is done in addition. And then we can differentiate between split depression, comminuted, mono, bicondylar, medial, lateral, posterior column injuries. The classification of Joe Schatzker from the late 70s was more or less a two-dimensional observation of the injury. The same was true with T.M. Moore, but he had a connection between fracture and ligament injuries and meniscal injuries. And only the last decade, with the Chinese computer supported classification, we started with a theory on 3 columns. this is very useful, and I think nowadays for planning indispensable. And of course, in your evaluation, the associated injuries like neurovascular ligament and ligamentous and meniscus injuries should not be overlooked. What now? So the timing of a reconstruction is crucial. You should not embark into an operation if there is a severe swelling, if there are blisters or a compartment syndrome. You need an intact vascularization, otherwise your surgery is in danger. If it is an injury with open wounds and severe swelling, the best we can do nowadays is a temporary external fixation in order to stabilize the fragments as good as possible. And this helps that the soft tissue can heal. Only when the blisters and the severe swelling is gone, you can start with planning your operation. Prevention of further damage to the soft tissue is the most important initial consideration in these fractures. Often compartments have to be released, and often it is a full thickness tissue loss which needs plastic surgeries as well. The treatment principles is, first of all, the timing must be accurate. A temporary stabilization is a staged protocol if there is severe swelling, compartment syndrome, or vascular injury. Then a meticulous selection of approaches after an analysis of the fracture. The analysis of a fracture nowadays is a CT and a reconstruction CT and a standard X-ray. Anatomical reduction of articular surface, condylar widths, and meniscal injuries is the goal. Congruity is the most important thing what we have to achieve. And to stabilize our fragments, we usually do that according to the buttress principle, and the plates have to be put accordingly. Here is an example of a complex fracture with severe swelling and a compartment syndrome. So this is stabilized first with a spanning external fixator, and later on, after blisters have disappeared and compartment is overcome, then you go for a definite reconstruction, often with the help of the distractor. This is a fracture of 71. We had no CT in those days, but with a good X-ray, you could also plan well and understand that the injury is a complex one and is not a simple lateral or medial condyle. In those days, we reconstructed the surface as good as possible and stabilized it with the buttress principle. And this is the secret in order to avoid early osteoarthritis. With the classifications of the fracture, we try to understand the mechanobiology of such an injury better. And one of these classifications was given in '79 by Joe Schatzker. You see, if you want to become immortal in traumatology, you must find a classification. And he did a good one, but it is only based on X-ray evaluation. And this is not sufficient nowadays. The same is true for T.M. Moore's classification. He, in addition to the fracture, he described the likelihood of concomitant ligament injuries, cruciate ligaments, lateral or medial ligaments, and menisci. If you look at this fracture here, It looks rather simple, like a monocondylar depression fracture, like according to Joe Schatzker's type 2 injury. But this is not the truth. If you go into detail, you see it is much more damage, as you can see on this survey. So a CT nowadays is, I think, mandatory because it only reveals the complexity of the injury. And then nowadays with the 3-column classification, we can better adjust our ideas to what approach we want to have. There is a small variation of this classification, 3 columns, saying that this part of the lateral column can be reached by an extended lateral approach. Otherwise, the Chinese 3-column theory expects us to do the reconstruction of the posterior column predominantly from posterior approaches. Here, such an example of a posterior approach. This corner really is very difficult to reach from an extended lateral approach, but with a separate posterior approach, you can easily buttress this fragment. Or here, with this complex injury, I think with modern imaging, the evaluation and planning has become more precise, and specific approaches improved the reconstruction and the stabilization of the plateau fractures. Thank you for your attention. Okay.
Yeah, you can say something.
Yeah, thank you, Professor HOLZ. We will take the questions after 2 more talks.
Yeah.
Second talk. Yeah.
Many, but
You can talk. There only you can talk. So you can talk there on.
Yes. Good morning, Professor STANNARD.
Yeah, you can talk.
Good morning, James STANNARD, Professor James STANNARD. Good morning.
Good morning.
Yeah, your talk is on surgical approaches to tibial plateau fractures.
Yes.
Yeah, please enlighten us.
Okay. Thank you for the invitation, and good evening to all of you, and good morning from the United States. I've been asked to speak to you about surgical approaches to tibial plateau fractures, and you'll see that there's quite a bit of overlap with Professor HOLZ's talk because your planning and strategizing really determines your surgical approach. So when I'm looking at a tibial plateau fracture, there are a number of questions I feel that I must answer. The first is, what is the soft tissue condition? And that may determine one of 2 things, either the timing of when I go and do this fracture, or potentially it may influence which surgical approach that I use. The second question is, what is the primary area on the tibial plateau in which you need to do most of your work? That will have a huge impact on which surgical approach. And then the third question is, can you accomplish your goals with 1 incision, or would 2 actually be less traumatic? And that is often the case. So the pattern and the soft tissue condition determines my approach. This slide will show you really the final answers of what my preferences usually are. And that's if you have a fracture that primarily involves the anterior or lateral side, I prefer an oblique straight lateral incision, or actually an extended hockey stick is what I like the most. If it's a combined column fracture, like a Schatzker 5 or 6, then I will tend to combine that incision with a posterior medial approach, both with the patient in the supine position. If it's primarily posterior medial, then I will do a posterior medial approach, and that can be either with the patient prone and an extensile approach, or supine, depending upon exact positioning of the fracture. And then for posterior lateral, the ones that Professor HOLZ just mentioned are in some ways the hardest ones to get to. I will attempt a straight posterior lateral approach, but if I cannot see adequately, I will go to a fibular osteotomy. An alternative to that is a lateral femoral condyle osteotomy, and I'll review both of those. So first, if the fracture is primarily a lateral sided fracture, these two are basically the surgical incisions you can use, either an oblique straight incision, or on the right here, you see my extended hockey stick. I prefer this one because it allows me to come back and do lateral side ligament work if it's necessary. And it also is a little bit easier for me to get down here to the fibular neck if I need to do an osteotomy. This is an example of what the incision can look like. As was mentioned, Kongfeng Lo brought our attention to the posterior column. Joe Schatzker and Mauricio Kafuri have recently kind of extended the thought to 4 quadrants rather than 3. And I think this is the most helpful for me when I'm thinking of things, because my approach, if the posterior fracture is mostly on this posterior medial around really to the middle or even over here, that is one incision for me. If it's over here, primarily involving that tough quadrant that Professor HOLZ mentioned, that really requires careful planning and different incisions. The classic posterior medial approach, you can see defined right here. This patient is in a prone position. His fracture was primarily on the posterior side, and so we made an incision across the popliteal crease and then straight down along the posterior medial border of the tibia. This will allow you to get an approach like you see in the drawing here by staying deep to both the medial head of the gastrocnemius, but also you must stay deep to the popliteus and elevate it up off the posterior surface of the tibial plateau. The tibia. An important thing that I don't like as much about having the patient prone is you really cannot see your reduction. So you have to work through the fracture and trust your imaging in order to get the reduction for the most part. But you get a beautiful view of the back of the tibia. As you can see here, as we're elevating up, this was a muscular patient, but we're elevating up that muscle and getting right onto the back of the tibia. An alternative that I will use more often is to keep the patient in the supine position so that I can deal with the lateral side more easily as well, and then place the knee in a figure 4 position while approach. In that case, I make the incision right here along the posterior aspect of the medial collateral ligament and right along the bone. The inferior landmark for me is the semitendinosus tendon, and you make sure to stay against the bone and anterior to popliteus. This shows the dangers that are present here, primarily the neurovascular structures. They average about 2 centimeters posterior to the joint, but you must stay right against the bone and know your anatomy in order to do this safely. So this is an incision that I did a little bit longer than in some cases to really demonstrate the anatomy. And here you can see the 2 tendons coming in, and we're going to stay right against the bone and work on either side of them and keep them intact if we can. This is using a Cobb elevator to elevate right off the back of the tibia. And this shows you the view that you can get with the patient in a supine position. It's very important. I have the knee flexed when I make the approach, but I have the knee extended when I make the reduction. And you can reestablish your medial column and get hardware on. And you can get about a little over halfway across the back, almost 2/3 from this approach. What about posterior lateral? These are the hardest ones, and these are the ones that you have to have a good strategy for how you can best do this. There are a number of different ways to do it. There's no one that's right or wrong. My preference, again, is to go in considering just a straight posterior lateral approach, but being ready to do a fibula osteotomy with or without Gerdy's tubercle osteotomy if I need to. That second choice is more invasive, but it gives really great exposure and there's a little bit more room for the hardware. So this is an example of a fracture that was overwhelmingly involving the posterior lateral aspect of the tibia. It was another one that didn't look like much on plain x-rays, but had severe comminution on the posterior lateral aspect. So we really wanted to see this for our reduction. So here you can see landmarks drawn. This is my hockey stick approach. This is the head of the fibula. About here is where the nerve is. And when you do an osteotomy, it starts right about where the nerve is. So you have to be able to find the nerve. This shows from the lateral the same exposure being drawn. So here's my incision. You can see that I've got a Penrose drain around the perineal nerve, and this is the top of the head of the fibula. Before making an osteotomy, I always drill so that when I put it back together later, I've pre-drilled my hole and it brings the fibula back to the appropriate position. So this shows you what all of that looks like. And this shows I've made my cut to begin with. I finish it with an osteotome. You're right near where the perineal nerve is, so you have to be comfortable with working around that nerve. And this is what the exposure can look like, though. We can see just how comminuted this fracture is. I'm looking right at the very most posterior aspect of the tibial plateau and can really try to put this together anatomically with those comminuted fragments to where my tibial plateau, here's my meniscus being elevated, and here's that tibial plateau being put together anatomically. So the view is phenomenal, but again, it's somewhat invasive in that you have to create that osteotomy to get that. Then I was able to elevate up under with some calcium triphosphate in order to hold that reduction, and then a very small plate finished the job. And that's what it looked like. Okay, if you don't like that idea because you don't want to deal with the perineal nerve as much, an option that my partner Mauricio Kafuri frequently prefers is the femoral condyle osteotomy. It will also give you great exposure, much less risk to the nerve, and the bone heals back and restores the popliteus and the lateral collateral ligament, which you're going to be dealing with. You can add a release of the anterior horn in extreme cases, but I don't like doing that because that potentially doesn't heal back as well. So this shows you, if you just do the anterolateral approach and a submeniscal arthrotomy, what you can view. And you can see about 2/3 of the surface, but you cannot see this back area. This shows my femoral condyle, and I've drawn around my popliteus tendon and my lateral collateral ligament so that I can then elevate up this entire area. If I do that, this is the exposure that I will get. You can see all the way to that back edge. And so it completely changes things once you have moved that osteotomy out of the way. And so you get a very beautiful view there as well. If you add the horn release, you really can see, but again, I prefer not to do that if possible. So how would I summarize things? I would tell you that for surgical approaches, I use the Willie Sutton principle. If you don't know who Willie Sutton is, he was an American bank robber in the 1920s. And they asked him why he robbed banks, and he said, because that's where the money is. I picked my surgical approach to go where the money is. Soft tissues are critical, and you want to wait long enough for them to heal, or in this case, do posterior medial or straight posterior approaches to stay away from that area. And I have a very low threshold to use two approaches. It's much gentler on the soft tissues. I think of things in terms of this 4-quadrant classification, so the Shasker-Kafuri, because this side is very different in approaches from this side. In summary, again, for just lateral primarily approaches, I prefer the extended hockey stick approach. For combined 2-column fractures, I will usually combine that with a posterior medial approach with the patient supine. For posterior medial, I'll do it with the patient supine, with the posterior medial approach, or with the patient prone and an extensile, depending upon what other things I have to address on this fracture. And then for posterior lateral, I'll use a posterior lateral approach, but be ready to add a fibular osteotomy or a lateral femoral condyle osteotomy. Bicondylar fractures require dual plates. Remember that, unless there's a very large medial fragment. Reduce and stabilize the medial column first, and learn the key surgical approaches to allow visualization and respect those soft tissues. Thanks very much, and thank you again for inviting me.
Yeah, you can.
Next, you have
Thank you, Professor Stannard, for an excellent talk. Now we request Professor Paul Tornetta to give his talk, How I Deal with Fracture Dislocations and the Posteromedial Fracture.
Can you guys hear me okay?
Yeah.
Okay, great. So I'm going to speak a little faster than the other speakers because I've got essentially a bunch of examples of sort of how this, how I like to approach this. These are my disclosures. I do design for Smith & Nephew, so a lot of the plates you'll see I had a hand in designing. I don't think that affects the principles. So you've heard already, these are a spectrum of injury, and the soft tissue injury is really going to drive a lot of these treatment methods. You've seen the Schatzker classification, which honestly I think has almost zero value anymore. You know, the Moore and Whole both looked at fracture dislocations, and what I'm going to focus a little on today is the thing that's most common, which is the total condylar fracture dislocation. But keep in mind that all these classifications have apples and oranges, and the AO-OTA classification is actually doesn't include dislocations at all. So a lot of these things have been missed over time. And here's just the common mistake. So over here, you see two different fractures of the quote medial side. The one on the right is a Schatzker 4. I mean, a Schatzker 4. He had only a few of these in his original article, and they were essentially older people with medial column impaction. And that's what this looks like. The one on the left is not a Schatzker 4, although it's commonly talked about, and that's the total condylar fracture dislocation, where you see there's subluxation of the lateral plateau. These are related, or outcomes are related to articular reconstruction, but most important when it comes to the fracture dislocation, it's related to alignment. Here you see a case that did not go well for somebody with still subluxation, and I'll show you the repair that was done for that. This was probably 18 or so years ago where these were not so commonly understood. The other thing I'd raise is that the risk of compartment syndrome is very high. We looked at this in our series, and although of 67 cases, only 17 were fracture dislocations, we had 9 compartment syndromes in that group. And most important, some of them occurred after the external fixation or even post-op. So when you put these things in a frame, when they start out short, you've got to really watch them very closely. So I just highlight that as a real potential problem. There are a couple of articles that looked at the posteromedial fragment in quote bicondylar plateaus, and both of these articles sort of missed the point because these fragments are frequently part and parcel of fracture dislocation patterns. They're not really bicondylar tibial plateaus. They involve both condyles, but they're fracture dislocations. So these are the two articles that both talk about this problem, but I think most of the problem is that they missed the boat on the fact that these aren't really bicondylar fractures. And why is it important? Well, because it's a missed injury. This is a frequent posteromedial fragment. And here you can see someone put a lateral lock plate on. It doesn't really grab the fragment. And you can see that if you do that, if you miss the fracture dislocation, you're off. The femoral condyle is still riding back with that one intact small posteromedial fragment. That's why it's so important to understand where these fragments are. So I'm going to go through some examples. I'm going to show you the typical medial fracture dislocation pattern and in two variants that I think are important. One is the anterior impaction with potential dislocation with a posterior portion that's intact. And the other is the fracture dislocation pattern that's dissociated from the shaft, because you can actually build that back to either a fracture dislocation or you can build it back to just a lateral condyle fracture. So this is sort of the simplest that you'll see. This is the same thing that we just saw that was missed. When you properly identify it, you can see that you can repair this through very small incisions. So I don't use big incisions to get up to the joint frequently, and I'll show you the incision that I use. So the initial management for this one, just as Professor HOLZ mentioned, these for us are ones that go into an external fixator. They get very closely watched for compartment syndrome. And you can see this is the typical total fracture dislocation, total condyle. And you get impaction of the lateral plateau, even though the fracture line comes through the notch. And that's because that's the area that goes up. So here you can see it in a frame, fairly well aligned. You can see the posterior aspect of it, and you can see that there's some impaction. Now here's the CAT scan showing that pattern more clearly. And you can see why, as you go laterally with the fracture dislocation force, the lateral femoral condyle impacts the more central area of the lateral plateau rather than the more peripheral area like you would expect. And there's that impacted segment and some lateralization of the plateau. This is what the CAT scan looks like. These are very, very common injuries. So what's your plan for this? I think just as Dr. Stannard just mentioned, I use frequently a similar technique. There's one trick I'd like to show you, which is I also don't like going prone. I do most of these supine with a bump under the contralateral side, and then I just switch the bump if I have to go lateral. But one of the things that's difficult is if you bring it to extension, it tightens up all of the posterior soft tissues. It's very hard to actually work behind the tibia with the leg in extension. It's much easier in flexion. So this is a little trick that I do where I keep the patient flexed, and then I place a clamp, and this is the article, you can look it up, it's just a technique article, but I put a clamp from the medial femoral condyle to the lateral tibial condyle, and that basically gains length. So here you can see that being done, right? What that does is it pushes the intact lateral plateau underneath the lateral femoral condyle, and that then gains your length, and then you can work in flexion with very small incisions. So here's what that looks like. And then percutaneously through the fracture site through about a, I don't know, 5 or 6 centimeter incision. It's not much more than that. You can elevate that joint surface, get that back up, and then hold it with K-wires from the other side. You can see there's some support that's needed, and there's a posteromedial plate going in to support it. And this is all done through a relatively small incision. So this is the entire incision. This is what I do for almost all of these. I very rarely need much more than that. And here you can see a close-up. So you don't need to see a lot. I differ a little bit from Dr. Stannard in that I don't really care about the PES. I take the whole thing down as one layer and then just repair the whole thing as one layer. I've not seen any problems with that. But you can see you can do these fractures to a very limited incision if you're in the right place. And I'll show you a little bit about where that should be. And then there's the way that plate sits in that fracture. This is the post-op film and the lateral. And then this is that patient healed at 1 year, actually did very well. Now, here's a more complicated one. I always like to show something relatively recent. So this is about a week and a half old. This is a 68-year-old rheumatoid arthritis who's on Humira and methotrexate. Clearly a very bad injury. It's a fracture dislocation pattern, but the lateral side really took a big hit in the process. So you can see on these CAT scans, and I hope this is playing well, but that lateral side is pretty well destroyed. Now, in a younger patient, I might do a dual approach, as Dr. Stannard suggested, and I'll show you an example of that. But in this particular patient, the idea was to avoid risk. So we took her off her Humira. We waited about 2 weeks. She stayed on her methotrexate, and then we brought her to the operating room. And again, same trick. So you can see just pushing over, even though that lateral condyle is not completely intact, you can get it basically reduced. So this is done supine. And here you can see I'm just identifying where that fracture is. And then we're going to tamp up that central impaction and then work all the way over and lift up the lateral portion of that condyle. Now, I think in a younger patient, I'd go after that directly. But in this patient, my goal was to get good alignment, get the patient to heal, and allow the soft tissues to heal, and then set her up if she needed something later, although I think she probably won't. But here you can see an example of that. And then I filled this because there was a very large defect with a phosphate cement to hold it in place. And you can see there's also a temporary plate. I use a lot of mini plates for mild reductions in the operating room. Then once that's accomplished, we go with an anteromedial plate to get that regular segment back, and then add a posteromedial plate to it. So there's the anteromedial plate, and then here's the addition of a posteromedial plate to support that whole side. And once that's accomplished, we can start to put screws across to support, first, getting the shaft medialized over to the medial condyle, and then second, getting fixation of that lateral side. You can see a drill aiming towards the notch a little bit. This arrow right here shows you, and this is a push screw. So the idea here is this screw is going to support that lateral side from falling down by being a locked screw. And you'll see that in the final construct. There's the lock screw. There's generally a good reduction. It's a couple millimeters off on the lateral side, which I purposefully elected to accept for her rather than add a lateral incision in a patient who really was at high risk for infection. So far, she's doing well. This is that same problem almost, right? But misdiagnosed. This was done at a hospital in Boston about 4 weeks ago. And you can see same pattern, right? So this would have benefited from that medial approach. Instead, they went lateral and ended up not correcting that subluxation. So this is what it looks like when you miss the boat. That's a lateral approach for a medially based problem. And you can still see that we're off over here on the lateral side. So this is likely going to need some kind of a reconstruction down the line because it was a misdiagnosed problem. Now, here's a 48-year-old skier with a total condyle. This one has anterior impaction. So this is a hyperextension fracture dislocation, which is a little bit different. And you can sort of see it here where the femur is really going anterior, leaving an intact posterior rim, which is an odd pattern, but it's one I think we have to recognize. And I've seen a bunch of these now. And it's a very short, shallow medial fragment that you have to deal with. So for this, it's a very similar thing, though. You want to bring the reduction over, right? You've got to change that pattern. So this is an under contoured plate that's going to solve that problem from sort of a medial / anteromedial approach. And here you can see as you put the screws in, you correct that, you're shifting everything back. And now we have a good congruent reduction. We're back to just a little better than neutral, which if you try to get them back to their normal posterior tilt, they usually will re-impact. So I try to get them to neutral a little bit better, but get them congruent. And then here's a worse example of that, which is that same hyperextension type problem. But here you see the fibular head is broken. It's a severe posterior injury. Here you can see it in a frame. This is the CAT scan. So you can see it as we're coming through that there's that very bad posterior affectation. And you can see posterior bone off. Now you could elect to do this prone. The problem with doing this prone is that the anterior bone is not intact. So if you do this prone, you really can't get to the front and the back at one time. So I tend not to do that. I tend to work on this in the supine position and just flop the patient back and forth to get posteromedial and then lateral. So here's the posteromedial plate, getting the posteromedial segment stable. And then this is the approach that I use. This is a little bit similar to what Dr. Standard showed. The one thing I like to do is I like to go very posterior to the tibia. And I don't take that whole incision. And the reason I like to be so posterior is because that's the angle my screws are going to go, so I don't block myself out. So through that small incision, this one I was able to protect the pes, but here you can see the fracture site. And then this is the plane of the fracture. And then here is the reduction maneuver. You can see pushing that up and in. So you can see that corner pretty well. And this is not a large incision. It's probably about 6 centimeters. And then this is the contour of the plate that has a little bit more of a bend to the back to really hug that posterior condyle. And, you know, I tend to slide things in and up and around a lot rather than opening widely. So you can see you futz around a little bit, but you can get that thing situated just right. And then there's that posteromedial plate being placed in, and add a lateral plate. At 1 year, that patient's actually doing very well. Now, here's another variant. And I think this is an important variant to understand. So if you look at the top half of this, it looks like a fracture dislocation pattern. But you've also got a separation between the metaphysis and the diaphysis. So this is lateralized, and that was part of the injury. But then also, you can see that the tibia itself is broken, as is the fibular neck. So essentially, if you look at it, you've sort of got a fracture dislocation pattern, but because that red segment is separated, there's also a dissociation. So for these, I think you have to still understand what the basic pattern is, and that this is essentially a proximal fracture dislocation pattern. The only difference is that the medial column is no longer attached to the shaft. So for these, what I tend to do is I rebuild it back. So here you can see the fragments. There's a big medial side. So what I'm going to do for this is I'm going to rebuild and make it into a unicondylar fracture. So I'm going to take this shaft, build it back to the medial side, and by doing so, with a bunch of lag screws and little mini plates, then what I've got is I've got a lateral condylar fracture. So now I can go in and treat this like a regular unicondylar fracture, only I am going to span this with a longer plate, but I don't need a big incision to do that. And then I can just slide a plate down to support that diaphyseal separation. And this is what that looks like because there's a big medial piece. And this is the finals on that. That's just the joint close-up. And then here's a very similar pattern with that diaphyseal separation. So it's not really a bicondylar on itself. It's a fracture dislocation pattern with some separation. You see some real posterior impaction here, and you see that subluxation. So fracture dislocation pattern, we're going to go in and support that on the medial side first, right? You see that clamp in place again from the medial condyle to the lateral tibial plateau to hold it in place. And then here you can see an elevator working through a metaphyseal window to elevate the joint up. And we're pushing it up further and further until it's reduced. And then capture that with some K-wires. And then you approach this from the lateral side, which I can get pretty far back without doing the osteotomies. And here's just an example of that. Put a little rim plate on to support that. You can see you can go all the way around to the back with retraction if you internally rotate. And here you see a rim plate fixing that posterior part of the joint on top of that. And there's a nice reduction of that lateral side. And there's the final construct. Now, here's a patient I started with to say this is a really bad problem that's frequently missed. So this is a patient who was 37 years old. I think I treated him in 1993 or 4. He had an ORIF and a hybrid frame place. It was removed at 9 weeks, and then he was referred to me at 12 weeks with this. So this is exactly what we're missing a lot of the time. It's the more fracture dislocation total condylar pattern. And you see it comes off, the back corner is off, and the fracture is subluxated. So there's that typical pattern that right now, hopefully nobody would miss, but back then a lot of people were missing it. There's the CAT scan showing the fixation that didn't hold. That's his normal side. You can see he does have a little bit of a lower medial condyle. So we're going to try to reconstruct that. That's my plan, to get a posterior medial plate on and then something across. There's the post-op film, and you can see the AP compared to the normal AP looks pretty good. And there's the lateral compared to the normal lateral. And he actually went on to do quite well with that osteotomy. But you have to make sure you don't miss these injuries, because these procedures are not exactly the easiest thing to do. And here's that same patient when he's healed. Thanks very much. And I appreciate you all listening to me.
Rajiv, you have to unmute yourself.
Yeah, now we start the questions. I'm not able to see the faculty.
Just one word.
No problem. Yeah, fine.
Thank you,
Yeah.
Mr. TORNETTA.
Thank you, Prof. TORNETTA, for a wonderful presentation. We have some questions from the audience, and some of the audience have sent us the X-rays and cases also for discussion. So we will put them to you.
Yeah.
Put that one, please. Put the first one that I sent.
Yeah, proceed.
Proceed. This is a patient. This is an X-ray of a 55-year-old person with history of injury. X-rays are apparently not of a very good quality, done in a government setup. How do you proceed, Professor HOLZ?
Well, as long as I don't see the character of the fracture, I will not do anything.
So proper X-rays first. Yeah.
So no, he was sent from the hospital that there is nothing wrong with you and you carry on, and then he landed. No, these are a few questions that we are getting, so we are asking. So then our next question is,
but after that, did you take a good X-ray?
Sir, I will ask the questions. This is they have come to us now, sir. Okay. Would you consider a CT scan or an MRI in this patient, Professor HOLZ?
Oh, first, I would do a careful clinical examination about the neurovascular status of the limb, and then I would first go for a CT. And if I'm not finding out the truth, I would probably, according to the symptoms, extend my diagnostic tools to an MRI. But that will be done stepwise.
Sir, anybody else with any other opinions, sir, from the faculty, or this is okay?
Well, get first a proper X-ray,
Yeah.
of course, a good clinical examination. And these are the ones where sometimes, I agree with Professor Olsen, the CT is what we do in most situations, but the ones which don't have any obvious skeletal injury and you have a lot of soft tissue swelling, etc., are the ones where I might go to an MRI rather than a CT. Okay.
Next.
Yeah, hey, it's Tornetta. I would probably start with a good X-ray first.
Yeah, that's what first is a good X-ray.
A good X-ray and a good exam, because if there's nothing I can see on X-ray and the patient has a stable knee, I don't care what the MRI shows. I'm not operating on that. So that's a waste of a study at that point.
Okay.
That's going to be a non-op management 100% of the time. Stable knee, no locking, maybe a meniscal tear that is being masqueraded by someone thinking it's a plateau, which is also going to be non-operative unless it's bucket handle or locked. So that's a good physical exam, a good set of X-rays. Nothing obvious that requires surgery gets no additional studies for me until they do some rehab and get some motion and repeat an X-ray in a few weeks to see if something shows up.
So that's what I said, that if I find there's a lot of soft tissue swelling and things like that, which don't fit in with the X-rays, I would get an MRI.
Okay. We did.
I think since we are in the meeting and we know there is something in the patient, and that's the reason we are talking about an MRI. In the casualty, if it comes in and your X-ray doesn't show anything, are you going to do anything? Here, I think something happened to the patient, and that's why you are showing it. But the first X-ray doesn't show anything at all.
Sir, it's on the contrary. I think your clinical examination becomes critical in these patients who don't have a bad or any obvious fracture. Okay, so if he doesn't have an obvious fracture, but he has got a lot of swelling, etc., or bruising, etc., those are the ones where you have to kind of have the red flags out.
Sir, in this case, we got an MRI scan done just for the reasons that are more possible here, that he has come to us from a different hospital and we need to show that we are a little better than them. So,
that's not a reason.
No, I'm telling you honestly.
Okay.
That I think. So we got an MRI scan done, and these are the MRI scan pictures. Yeah, go on. These are the coronals. Yeah, these are the sagittal sections. Axial. Yeah, this is the axial, probably the most required. Now, how would you proceed? He's a 55-year-old person. What is your advice for them? There is a lateral column, and there is a small central depression. Is this acceptable? Is it okay, or should it be fixed?
What was the exam like? We haven't gotten.
Examination was that he came to us with pain in the knee. We told him not to walk.
Any instability in the knee when you're in extension and 30 degrees? Is there any valgus instability in the knee?
Yeah.
Apparently did not appear much, sir, but because of his initial this thing, we didn't examine him so forcibly.
But when he has come with the pain,
yes,
I'm asking you, Dr. Tornetta, when he has come with the pain, this instability is very difficult to examine there at the time when he has come just with the pain there. If there is a severe pain and a swelling.
Yeah, so there's a couple ways to do it. One, you only need to get one exam, so it's uncomfortable. But if you see nothing on the X-ray, those patients can usually tolerate an exam because they're not markedly displaced, right? So the patient with the X-ray looks essentially normal. I think I can examine those patients almost every time.
But if in case there was a good X-ray, we would have been able to see the depression.
Yeah, so I think if you had a good quality X-ray here, you would see this fracture. You would see that it's not very displaced. And then you would see you've got a little crack over here, and you do an exam. And if they've got a stable exam, depending on the age of the patient and their requirements, you might move to an MRI to look at their meniscus, although I typically do not do that. And I would treat it non-operatively. I've treated, 70, 80 of these non-operatively when they have minimal depression and the intact meniscus. Yeah. And if you look at the data, that's highly supported in the literature. It's not articular step-off that's the problem. It's the meniscal injury that's the problem. So I'm highly unaggressive for patients who don't have any instability, minimal amounts, a couple of millimeters of depression, unless it's in the anterior loading area and they're a runner or a heavy impact activity person. But these are not X-ray diagnosis, then make a decision. This is talk to the patient, find out what their needs are, understand the loads that the knee is going to see and the potential for arthritis, and then make a joint decision with the patient. These are not objective decisions.
I agree with Dr. Tornetta. If you really look back at initial principles from Joe Schatzker 40 or 50 years ago, stability was the key determinant, not how many millimeters of depression that you had. And so if it's significantly depressed, you'll get instability. And I think you can, again, work with your patient and get them to tolerate one good exam.
Okay. So this patient undergoes conservative treatment.
If they're completely stable, yeah.
I think so, but if the patient, for me, if the patient had a stable exam and they're a middle-aged person whose basic goal is to walk around and not get arthritis, I would treat it non-operatively. If the patient was a marathon runner, I think, you have to have a discussion with them about what potential wear and tear is there. And I would probably get a CT with coronal plane reconstructions to really understand where that deficit is compared to the meniscus. Because if the meniscus stays intact and doesn't get eaten up, that they're going to do fine.
And so there is another question.
Another question to Dr. TORNETTA from Dr. Ajay Rao. How do you do a posteromedial approach in the supine position?
So what I do is I place the patient on a flat top table, because typically I like to get to both sides at once, just like Dr. STANNARD and Dr. HOLZ sort of recommended. So I put a bump under the contralateral side, which then flops the affected side over a pretty fair amount. The problem with that position is then when you flex them up, just like Jim said in a figure 4, you tend to get varus. And that's the problem with that approach, right? You tend to get varus. So the way that I offset the varus is I put something underneath the thigh, and then that clamp that I showed is really the solution to all of my problems. Because once I pull the lateral tibial condyle back underneath the lateral femoral condyle, I have length again. And then you can directly work on that posteromedial fragment from a 6 centimeter incision almost behind the knee. And because the incision is so far posterior, you have to track up in front of the gastroc to pull it down. But when you're looking in, you're actually in the axis that you want your plate and your screws to go. That's what causes people to use very long incisions, is because they center it over the tibia. And then to get all the way to the back, you have to pull the skin back. So I do these all through an incision that's about what I showed you. It's really not much longer than in any case. The only time I extend it proximal to the joint is if I don't have a really good indirect read, like sometimes there's comminution at the anterior edge of the fracture, and I want to see the cartilage, I'll extend it up to the joint, lift the meniscus up over a 5 millimeter area and look right at the articular reduction. You don't have to open it up with a submeniscal arthrotomy, but you can extend it up and see that location where it goes through the joint. But then to do the lateral side, you have to take the bump out and have someone go underneath the drapes and put the bump under the other side.
So if
Thanks, sir. We go to the next lecture series of 3. We're having a lot of questions coming in from the audience. I think we will take them a little later after the third set of talks.
Sir, HOLZ, sir. Now your talk is how I deal with bicondylar fractures. Professor HOLZ.
Yeah.
So your talk is how I deal with bicondylar plateau fractures. Will you please enlighten us?
What will be? Can you repeat?
Bicondylar plateau fractures, how I deal.
Yeah.
How I deal with
fractures.
Yeah, yes, sir.
Coming.
So that's your next talk. That's your next talk.
Coming.
Professor HOLZ, you could please share your screen, sir.
Is this okay for you?
Not yet, Professor HOLZ. I think you need to share. Go down to that green sign again at the bottom and share screen.
It is open?
Not yet. No, you've got you have to go to, yeah, now you got it.
Hopefully.
No, not yet.
No.
Have you got your presentation open?
Yeah, it is. It is.
Okay. Maybe you're on the wrong slide.
No. Yeah.
Just open your presentation, minimize it, and then share screen.
Here?
Okay. Go to share screen. At the bottom, the green sign with an arrow. Yeah, now you need to pick on the presentation that you need. I think that's it. So maximize it now.
That's it. Bicondylar fractures. Can you hear me?
Yes, we can.
You can.
Yes, we can hear you very clearly.
Okay, so that is the lecture on the how I deal with bicondylar fractures. Sorry. It is recommended to start with the reduction and stabilization of the fragment of this fragment, which is a simple fracture type. This is easier and gives you a certain stability from the beginning. The fragment is fixed to the meta and diaphysis in order to get a stable column. And with a stable column, then you can decide about your further steps of stabilizing the other condyle. Here is, that fracture had a big medial part, a comminution, extending almost into the lateral posterolateral area. And this was stabilized simply by 2 plates with an incision posteromedial to support the posterior pillar, the posterior plateau, and then an additional plate to stabilize the whole thing. In case 2, you have a posterolateral fragment, a posteromedial fragment, and this was treated. Here you see the fragments depressed more than 5 millimeters with a lateral approach and a posteromedial approach. And at the end, you have then here is a little bit of a gap, but the plateau itself is rather smooth. So I think this is an acceptable reconstruction. Sometimes this is now not a bicondylar fracture, but it is a very difficult fracture to manipulate. It is a posterolateral depression fragment. And of course, you can go now with an extended lateral approach or with a posterior approach to attack this fragment. But there is an elegant procedure which we call the push screw. I learned it from Dr. V.M. Shah in Gujarat. He pushed up the fragment with a screw and then underlined it with a rafting screw in order to stabilize it. And the whole thing, because it is a big lateral condylar fragment, at the end we put a buttress plate in order to stabilize it. So with this push screw technique, you avoid difficult approaches, but it works only in fragments which are solid. You cannot elevate crushed fragments. It's not possible. Here we have now a more difficult bicondylar comminuted fracture. Here it is a medial and posteromedial fragment. You see the medial fragment, the posteromedial fragment. This is the posteromedial fragment with a huge gap. This is approached by a posteromedial approach. Here is the pes anzerinus to be seen. The fragment is reduced, stabilized provisionally by a sharp reduction clamp. those that the surface is smooth, stabilized by K-wires provisionally. Here again, you see the pes anterinus, which is undermined. And of course, for this procedure, you have to bend the knee. Otherwise, you will not be able to come to this posterior medial part easily. So you have to bend the knee, and then the muscles and everything, the pes anterinus is released, and it's no problem to place your plate from this posteromedial approach. And then the other column, the lateral one, is approached by a lateral approach, according that what we have already heard from Paul TORNETTA and from Dr. James STANNARD. We know that this is a very, the lateral approach is a very you can have it as an extensile approach and have a good overview. The menisci are are fixed with a small suture. You can see into the joint, you can place your plate properly, and you can fix it accordingly. So at the end, you have a solid reconstruction of both of the columns with two approaches. Here is an other classification which was came up only recently with 12 segments. I think this is a little bit too much for an ordinary orthopedic surgeon. But what he wants to say is that each of these segments should have a different thoughts according to the approaches. And in this schema, you see that most of the fractures can be approached by the patient in supine position. Prone positions with posterior approaches are very rare. Most of them you can tackle in a supine position. Here the posteromedial and posterolateral fragment depressed. And stabilized. Here the depressed posteromedial fragment lifted up and supported by a posterior plate. Here the posterior plate, and then at least the whole double, the bicondylar fracture stabilized by a second plate. Anterior, medial, and posterior column fracture. Here, posterior, anterolateral, and medial by two blades, one from posterior, extended posterior approach in prone position, and then an extended lateral approach in supine position. These areas, these blue areas in the posterior column, I think this we can only really well attack by a posterior approach. This fracture we have seen a similar one from Paul TORNETTA, a fracture dislocation. Usually the meniscus is torn and often entrapped into the fragment. This is the big chunk of the posteromedial fragment. And you start with this simple fracture first. Step one, posteromedial approach to a rod to stabilize the medial column. And then you go to the lateral column. You may use a distractor, a small distractor, in order to open the joint to get a better view to the surface of the lateral condyle. And that's the posteromedial, and that's the lateral stabilization. During and after the reconstruction of the plateau, the menisci and ligaments should be checked carefully. Tears in the vascularized part of the meniscus should be repaired. If ever possible, you should not remove a meniscus because the meniscus is protecting the surface of the plateau. Recently, 3 days ago, I got this picture from an Indian friend with this bicondylar fracture. And he asked whether this is a good reconstruction or not. If you look at these postoperative pictures, you say, okay, it looks quite well. But if you look a little bit closer to that, you find two things. One is a little bit valgus, and the second is the width of the tibial plateau is not the anatomical one. It is too broad, and the problem lies in here. The reduction of this lateral condyle was probably difficult because of a comminution in the middle of the joint around the eminentia intercondylica. So you should not be satisfied with a picture which does not show fully the surface. You should always postoperative check it properly. And if you are not sure, you should not be shy. You should go for a CT, postoperative CT in addition. So thank you for your attention.
Yeah, thank you, Professor HOLZ. We will take the questions again after 2 more talks. We request Professor TANNA to talk on failed fixation of tibial plateau fractures. How did I manage? Professor TANNA. Professor TANNA, please.
Yeah, I'm here.
Yeah, thank you, sir.
Now here is in about somewhere in late 90s. This is the surgeon was lazy. I'm heard, no? Am I heard or no?
Yes, I hear you.
Yeah. So the surgeon was lazy, and this is how he fixed it up. And here was some CT was done for some other reasons. You can see he made this calcaneal traction or a tibial traction, I think calcaneal traction. So this is how it is. Now it is already 4 months. This is not functional. And here it is the marked deformity. As you can see it here, there is a flexion deformity. The patient cannot walk about. This was deformity 4 months, unstable to walk, unable to walk. Now this is the stage he came. Now with this sort of a situation, this sort of a tibia, everything is overflowing as you can see here. Osteotomy to correct the flexion deformity, intra-articular malalignment, and break the malunion to realign or to leave it alone. Even this is not even suitable for the future TKR if you want to do it. And hence this is the one which needs to be corrected upon and at least keep it ready if in case if you need a TKR for the future. So now it is the planning which goes into the picture. So this is what it is. Here is the fracture, and as you can see, it is overflowing. So here we will have to do the osteotomy to compress this. Here is the one which has been going out. So you will have to probably correct that. The axis is not all right. As you can see, the axis of the tibia, which is the very, very important thing, there is the angle of 18 degrees. And at this stage, there is the cora. So you'll have to do the osteotomy at this stage in order to correct the varus. So you'll have to correct the varus. You'll have to do this intra-articular osteotomy to correct this really widening of the tibia. And also you'll have to correct this. So at this level, 7 centimeter, all this is the planning which has to be done. Unless you have done the planning, you will not be able to really execute this surgery. So this is what is done. And now we are ready with the planning. At the 7 centimeter, we'll do the osteotomy to correct the varus. We'll do the intra-articular osteotomy to correct it. And posteriorly also we'll have to correct it. So here it is. So we'll have to rotate it. So this is rotated now. And here also we'll have to correct it and probably fix it up properly. So this is the osteotomy. So now here is the complex osteotomy. You will have to really go ahead and do it. So this is what is ultimately boils down to. This is how it has been planned, that you will have to all the fragments you will have to realign. Now having realigned it, now having done the picture, this is on the medial side, there is going to be a gap here, as you can see it here. So you will need the graft here. And this whole thing will have to be on the lateral side and the medial side. And tracing must be done for all corrections. Once you've done this tracing, then probably you are in a better position. And here it was corrected, and here is the graft which was required. This is what was put in. And you can see here, the whole thing has been corrected. And ultimately the whole thing was situation. This is, as you can know, ultimately it came down to, this is also came down to, it was an intra-articular osteotomy. I did that, and the whole thing ultimately is held up. And you can see 0 to 60 degrees, the range of movement, and the limb is straight. He can walk about, move about, and he can do everything. Now in these situations, unless and until this is corrected, you are not going to get the patient moving about and walking about. And even if in case now after this correction, if ever in the future he needs any surgery, then TKR is not difficult at all with this surgery to be done for the TKR. And as you can see, you after doing the intra-articular osteotomy, you will have to compress the fragment in order to get all these things aligned onto the lateral femoral condyle. Once it is done, then only you will be able to do it. Surgery went as planned, but intraoperative, the knee could not be flexed. And then grudgingly, I had to do a transverse osteotomy of the patella. I'm not sure whether it was the right thing or no, but after doing the transverse osteotomy of the patella, I could do the whole thing. Now here is the second case. It's the 6 weeks after the conserved. I don't know, this is how it was conserved. Unfortunately, even the CT scan, which is there, but still the surgeon decided to conserve. He felt he wasn't up to it. So now once it has been conserved, and 6 weeks later he comes over. 6 weeks is a good time to go down. And you can see this is the medially, it is there. The whole thing has been depressed medially and it has been opened up. So once we went down and I did the medial osteotomy. The medial osteotomy was done, and you can see the break here. So this was corrected. And here once the medial osteotomy was done, epicondylar osteotomy was done. So that was corrected. And ultimately everything was put back in the position. And the approaches and all has already been spoken about. So this is how it was done. It was fixed it up. It was all elevated here and then temporarily fixed up. And you can see now it is temporarily fixed up with this wire. And now it is the whole depression has been corrected. And once it has been corrected, this is how it is ultimately. This is it has been epicondylar osteotomy is fixed up with the screw, and this is completely corrected. And then he had a stiffness. So he had a stiffness. Ultimately, the stiffness, which was again arthroscopically, it was reviewed, and this is at the 2 years time, very decent range of movement and pain-free joint, and patient is moving about and walking about. So I think it is very, very useful to realign the knee joint. You may not get 100% result, but you will definitely be able to tide over at least 10, 15, 20 years. They may get an osteoarthritis later, but I feel this is very, very worth it in order to correct this sort of a deformities. Now here is this other. Here it is the fracture which was treated like this, and this is how here the patient had a range of movement. He couldn't extend it fully. This has already been like this. This is how he was treated. You can see again there is an overflowing which is occurring. So all these fragments you can see. Now this is the stage he came over. This was again 4 months after fixation, walks painfully, movements of the knee are not there as I showed. The surgeon had done these mini operations. And here you can see the CT scan. This is the one which is splayed out. This is the one which is really splayed out. Fortunately, the posterior-medial part is not very badly affected. So it is much simpler surgery comparatively than the other one. You have to go down here and do the intra-articular osteotomy. And once you will be able to find the judge here, the white shining articular surface and the fibrous tissue, and again the white shining articular surface. So in this area, you do the osteotomy. Here it is how you can see it very well. Open the joint by a meniscus reflecting intra-articular osteotomy. This is the osteotomy, you do this. Once you've done this osteotomy, this has to be a fairly big bone which has to be kept in order to really compress the fracture. So you've done this osteotomy and all this area. Once you've done the osteotomy, it's not very difficult to find out the really white shining articular surface and white shining articular surface. And all this is the fibrous tissue, which you will have to go on slowly excising it out. And having excised it, now this is having done an intra-articular osteotomy, junction of the white shining articular surface and the scar tissue is obvious. And remove the scar tissue and fix that. Now here it is. It has been fixed up. It has been fixed up. Articular surface and everything has been fixed up perfectly well with the lateral plate. And here is the range of movement. This is 3 months. It is a good full range of movement there. And this is a 10-year. This is a 10-year thing also. Patient has this is the 10-year result. You can see it there. And has a full range of movement which is there. This is the full range of movement which is there. So I feel, now here, I feel the MIPO surgeon are very good talkers and they really sell that MIPO surgery very much to the people. This was a small fracture like this and the surgeon had to do the surgery. So he put it down, seeing at this X-rays, he put it down the lateral 2 screws in order to fix it up. This is how he has fixed it up. And as you can see, the whole thing has started collapsing after 2 months. So this is what it collapsed and this is what it is. Now here was the day 1 picture. This is in about 2 months' time, this is what is the picture. And so at this stage immediately, which was there, and afterwards it went on collapsing it. And so I did the CT scan. And you can see what he has done is, the fragment is here. He has put in the screw at one edge and he has already really splintered the fracture. If he had done the open reduction, he would have gone into the middle of the fragment and would have done the leg screw. And this is what it would have been done. So it just in order to remain purely onto the radiological and fixing it up, this is how it was really gone ahead. And once you did the CT scan, you realize it. In the hindsight, Livil alone could have been better than this screw. Open surgery wouldn't have allowed this mishap. So I think this mini surgery, and he didn't even do the CT scan to find out where is the fracture. All 4 patients, same busy surgeon continued his life, thanking the doctor for a wonderful minimally invasive keyhole surgery. And this is how the whole thing goes on. Here is the next patient. Again, Aliza Rao, that was an Aliza Rao mania in that particular surgeon. There's such a simple fracture, he fixed an Aliza Rao. Fixed with the Aliza Rao, got infected and the whole knee joint is fired. Pin track infection and everything is fired. So ultimately he went up into this, I had to do the knee joint arthrodesis. This is the knee arthrodesis which was done for such a simple fracture, it ended up into the knee arthrodesis. He wasn't willing for the total knee at that stage and never a MIPO in a joint alignment. This is how it is. And then what happened is, after 4 years, he again fractured this. The whole fracture and knee arthrodesis is held up, but he fractured here. So this was the most interesting part of the surgery afterwards. This is how it is. I removed the implant closed without opening it up. He removed the implant, and when the implant was coming out, this is a hook which was there from the distal fragment which was coming out. And then when it was coming out, this hooked wire from the inside the nail which I had passed. And then I realized then the way the hooked wire goes in and the whole screw comes out. And then there is it wasn't coming out through the same hole. So the wire which was, I had put it inside, I put it outside. This was the inside wire. I put it hooked wire outside. and put in a small Stillman pin in the nail to redirect it to the point of opening. So once it came out, and then it was much more easier. You can see it has been fractured into 3 areas. And then it was re-nailed there, and this is how it is. So I feel this is again a 27-year-old conserved 10 weeks pain. This is how he just carried on because the surgeon didn't do it. This is how it was, but the pain was quite significant. So we did the CT scan. There was a depression. He was a young man. This is how it is. There was a depression here. And then there was a comminution there. So once we went there after that, and I had to do the osteotomy there. So I did the osteotomy to realign. As you can see here, to realign remove the scar tissue from there and put it back. But in the bargain, what happened is, you can see here, this is what is the fragment. This is the fragment while I was trying to remove it, try to realign it. It just came down. Fortunately, it didn't go on the ground, but it came down on the operation table. It came down on the operation table. I put it back, put the leg screw, elevated the fragment, put in the hydroxyapatite there, compressed it, and then ultimately the whole thing was held up. Sorry, I think one X-ray is missing there. This is the other patient, young lady, young girl. The surgeon went down and did only on the medial side because this is a big fracture. The lateral fragments, it didn't do anything. And this is how it was in 6 weeks' time. It was quite painful, and ultimately, patient was willing for surgery in about 3 months' time. So again, the same thing, intra-articular osteotomy, correcting the whole thing. I removed 1 or 2 screws and kept the plate there, compressed it with the leg screw there. Fully it was done. And then it was operated upon, fixed it up. And 1 year, this is what is the picture. And there you see the full range of movement there. So I feel once there is the fracture is not doing well, and if the pain and symptoms are there, it's really worth going down and fixing it up. This is the last case I'll show because my time is up now. This 33-year-old doctor male, injury to 3, operated by a local surgeon. This is how the fracture was. And just he had done these depressed things and everything. He had seen this before surgery. But this is how all these things was there. And in spite of this, seeing it, he just fixed it up. He put in a medial plate and he put in a lateral plate without doing anything. And you can see how much of it is outside. And this is how it was done. Unfortunately, this was a doctor in the periphery. So he came over. And it was I think it came around, if I remember, around 5.5 months or something. And so this is the reason, again, in intra-articular osteotomy, this is how it was. So again, I did the CT scan. And you can see the whole thing which has been there. There is a depression there, and this is the posteriorly, it has been displaced. So with the CT scan which was done, now at this stage, the whole decision was whether to go down posterior medially and do that, or only the lateral correction which we do it. So I went down, you can see the whole fragment there. So I went down, did the osteotomy, did the intra-articular osteotomy, elevated the part, put the articular surface. This was all crushed bone. This was all crushed bone, elevated it and put the graft there. And this is how ultimately, this is the best we could get out of this. Now, being a young man, he has been advised that once it has healed up, this hyaline cartilage has been affected. So this is the one which does very well if it is a small part of it by doing a hyaline cartilage transplantation. So this is the one which I had advised to see, one of those people who has been doing it. But he says, I have no pain, and that's the reason he has just carried on. So I think in conclusion, I feel that if the fracture is not doing very well, and if the pain is there, and if you can see radiologically the things are not doing so well, it's worth going down and correcting the whole thing. And I'm sure the patient will definitely benefit out of that. Thank you very much.
Okay. So can I be heard?
Thank you, TANNA sir. Good evening, John MUKHOPADHYAYA. Will you please enlighten us on tibial plateau fractures management? Hello.
So, Professor Tanna, if you can stop sharing your screen.
Now, if you share, I'll automatically stop.
Okay, no, I thought you have, okay, I'll do that. No, I can't, it says I can't share till you stop.
I have stopped it.
Okay,
I have
now
stopped it.
okay, so
You're on time.
good evening, everybody. I think there's going to be some overlap, but I'm basically going to concentrate on intra-articular malunions of the
Actually,
gentleman who presents 6 months after the injury. I'm going to deal with this case a little later, but I think what are your options here? Do you just advise them physiotherapy? Do you give them intra-articular steroids? You tell him to wait till he's bad enough to have an arthroplasty since he's already 50, or do you plan a surgical reconstruction? Okay, the problem is that we get all these various deformities or inadequately reduced fractures. In spite of all our advances today, we still continue to see these problems, and we have to find a way of dealing with them. So you need to assess them clinically in terms of their symptoms, disability, instability, and range of motion. And then you need to assess them radiologically as to whether this is an extra-articular problem, intra-articular problem, is it combined, and you need to look at the joint incongruity. So you need to do your standard AP and lateral x-rays, you need to do your full-length weight-bearing films, and you need to do the CT scans to really provide you details of the geometry and the deformities and the various parts of the condyle which are affected. So your treatment strategies could vary from extra-articular osteotomies to intra-articular osteotomies and plateau hemi elevation or elevation of a depressed segment. You may need to do combined procedures, and in some of them you may have to do complex reconstructions. And I think some of it has been gone through, but we'll go through a series of cases starting from more simple ones to more complex reconstructions. So here's a 41-year-old gentleman who came to us a year after his injury, and you can see there's the line of the previous fracture can still be seen, it's united, but you can see the depression is of the medial condyle and really involves almost the entire medial condyle. So here you would plan your osteotomy along the previous fracture line, elevate this hemi-plateau, and then put in bone graft. So that's what we did. That was the line of the osteotomy, the elevation of the hemi-plateau, the bone graft, and a buttress plate in this case, which could be put on the medial side. You didn't need to go posteromedial because the entire medial condyle was involved. This is him after correction. You can see the overall alignment is also okay. And this is him 1 year post-op with a good functional result and a good range of motion and maintaining his joint satisfactorily. Sometimes you could have a varus deformity, which is intra-articular as well as extra-articular. This gentleman who had his injury some years ago and came to us, he had a range of motion till about 80 to 90 degrees of flexion, but he was having pain on walking. So here we decided that we need to do an intra as well as an extra-articular osteotomy. So the intra-articular osteotomy was through what we could see of the previous fracture line, and we added an extra-articular osteotomy to correct the sort of varus deformity in his overall limb alignment. And this is him at follow-up. He's got a range of motion to just above 90 degrees, which is slightly better than his pre-op range of motion, but he's maintaining his correction and good alignment as well as a joint line at this stage. Now you can have segments of the articular surface that are depressed. That means not the entire condyle, but a segment of it. This is a young lady who came to us about 3 months after her injury, and she had this instability in flexion. That was her main problem, and was actually sent to us as a ligamentous problem. But when we saw the x-rays and the CT scans, you can see this posterior posterolateral depression here, where this is sloping down in this direction. You can see the edge of the condyle is okay. And in a situation like this, we'd go through a lateral approach, we do our submeniscal arthrotomy, and then through the line of the previous fracture. So you make a window through the line of the previous fracture. So that's with the saw, you complete it with an osteotomy. And when you take out the lateral condyle, you can really see the depression of the lateral condyle very clearly. Okay, and because this was 3 months old, you could still see a fracture line there. You go down to the fracture, elevate it with this entire segment of subchondral bone so that you have good supporting subchondral bone under the articular surface. You push it up all the way to the lateral femoral condyle, put in your K-wires, which you can put in through the lateral side and take them out medially so that it doesn't get in your way of your fixation. And here we would use some calcium phosphate crystals or some bone graft as would be necessary. Here we use calcium phosphate. And then we close the lateral wall back on and then buttress it and fix it with a plate adequately. So that is the post-op reconstruction. This is her 6 weeks post-op, and this is a year post-op. Again, maintaining a good correction. She's got a full range of motion and no instability at this stage. What about the posteromedial condyle? So here's an example similar to what was shown earlier. But here you can see this is a pure posteromedial condyle. Okay, again, if you look at the CT scans, you can see it's a dislocation similar to what Paul TORNETTA talked about. You can see here's the big step off there on the posteromedial side. And this is what you need to correct. And these are ones where possibly going through the posterior approach makes it easier. So that's her in her prone position. With the C-arm image, you can see the distinct double shadow of the medial condyle. And you have to make your osteotomy through the edge of this along the line of the fracture, take it up and elevate it. So now when we've elevated it, you can see there's a single line on the medial side. We put in a lag screw, we put in bone graft, and then we put a buttress plate. It's a flat T plate posteriorly. And that was the post-op X-ray. This is her at follow-up at about 18 months. Again, she's doing well. You can see how she's maintaining her joint line and a good range of motion. So coming to more complex problems, here's a patient who was operated on and came to us late with this kind of fixation. Again, if you look at the CT, you can see that there's a huge depression here on the medial side and this step off here. And these are difficult. This is where you need to do the epicondyle osteotomy to really get a good visualization, as was mentioned by Dr. TANNA. So that's the medial epicondyle osteotomy. That's the huge step off here, which we need to get reduced adequately, correct it, and then put a lag screw from front to back, and then put a buttress plate on the posteromedial side there. And this is him. Maybe I could have gone more posterior with the plate, but he's got a bit of varus, but otherwise a good function at the end of 1 year. Another complex situation where you have this displacement of the lateral condyle completely. If you look at the joint line, that is in varus. So you have an intra-articular as well as an extra-articular problem. So here you will need to take off some bone here with the fibrous tissue. So your osteotomy is actually going to have to take off that segment of bone to be able to get this fragment reduced. So we do the intra-articular as well as an extra-articular osteotomy. This is a lag screw across to compress that, to get that under the lateral condyle of the femur, and then a buttress plate to hold it. And this is him at about a year's follow-up, doing reasonably well. This is not a perfect result, but doing reasonably well considering his situation. So coming back to the case that we showed initially, again, you can see this lateral depression here, which is more posterior, as you will see in the CT. And you can see a double shadow here, which is a split depress in the medial condyle. So those are your CTs. You can see the posterolateral huge depression there. You can see the split depression on the medial side. You can see that on those sagittal films. Those are the 3D CTs, which are not great in this particular case. But so here what we started off with is making a lateral window similar to what we did in the first sort of case of the depressed lateral condyle that I showed. We opened it up. And here you can see the depressed part in the posterior part. This is the articular surface. This is the articular surface in the front. And this is the depressed part. And we just loosened up underneath here where the depression was. We didn't go on with this part of the fixation. Then we went to the medial side. We did a medial epicondyle osteotomy. There is the step off where we do our osteotomy through to the posterior side. We get it reduced adequately. Then we put a lag screw from front to back and a posterior buttress plate there, and then repair the medial condyle, epicondyle osteotomy. And we go to the lateral side, and that depressed fragment, which I showed you earlier, we are pushing up with a bone tamp. And this defect here, we put in bone graft. So that's the bone graft going in that area. Now we still have the problem of the lateral condyle wall, which we have to put back. And being 5 months or 6 months old, you're not going to be able to reduce it. We have to take off a segment of bone from that. That's a segment of bone being removed from this lateral condyle fragment. As was mentioned, you need to leave adequate bone to be able to fix. You nibble out whatever fibrous tissue, etc., that you have till you can close this gap in completely. You put in your K-wires, you compress it, and then you put your buttress plate across there. And this is at the end of the fixation. Post-op X-ray, again, you can see how nicely the joint has been reconstructed here. This is him at 4.5 months post-op. This is him at 9 months post-op, and this is him at 15 months post-op, walking pretty normally, considering the kind of fracture that he had. So I think it's worth reconstructing many of these, and some of them can be even more complex with ligamentous problems at the same time. This was a young gentleman who had a femoral shaft fracture and also had a proximal tibial fracture, which was initially missed. They discovered it about 7 days later. Then they fixed it with these screws. And again, you can see this is an inadequate fixation. And I can see this fragment of bone that has been avulsed from the lateral epicondyle with the lateral ligamentous attachment to it. So here, what we had to do was, again, this was the situation he came in. This was him. You can see the varus deformity and his instability. He has struggled, his knee going into varus when he tries to squat or kneel. Those are the CT scans. And here we did an osteotomy through that area. We put in bone graft, so we got the condyle leveled up. And on the lateral side, we reconstructed the lateral collateral ligament. Luckily, there was a reasonable sliver of bone, which we could fix on with a spike washer. And this is him at a year post-op, doing quite well. He had a bit of a wound problem on the medial side, late wound problem. So we removed the plate, but this is him at 2 years. He's got a good stable knee and a good range of motion. Unfortunately, everything doesn't go well in these, and some of these problems can be quite difficult to deal with. This gentleman was operated late by the first surgeon. It was operated at 4 months, and this is what he did. So he did a reasonable job, I thought, with the medial side, but the lateral side, the whole condyle was out. And he came to us 8 months after that. And so we went in and did all the reconstruction. We left the medial side thinking that is reasonable, but we took off a bit of bone on the lateral side, compressed across it, and thought we had a fairly good reconstruction. The other problem was this patient was absolutely stiff. When he came to us, he had hardly this range of motion of about a fixed flexion deformity and hardly a jog of motion. So we tried to mobilize the knee as much as we could. We got about 40 degrees on the table. This was him at about 3 months. We did an arthroscopic arthrolysis and got him to about 80, 85 degrees. That's the maximum we could get. Unfortunately, in the follow-up, his physiotherapy kind of used a bit of force and then broke his femoral condyle. Okay, so he came to us with that, but he didn't want any further surgery. So we gave him a back slab for some time, waited for the fracture to heal, and then mobilized him. And this is him at his last follow-up. He's straight, which is good because he can walk okay. He's got a flexion to about 40, 45 degrees, but that's his range of motion. But he does not want any further surgery. He's reasonably happy with it. Interestingly, we also did a CT scan to look at our reconstruction, and it looks reasonably good. It doesn't look great, but it looks actually, we've been able to get the condyle reasonably aligned, but he has a stiff knee because he started with a stiff knee and we couldn't do too much for him. So I think in conclusion, these intra-articular malunions need careful assessment. We need to look at the clinical problem and the possibilities of reconstruction. Plan your osteotomies carefully to correct both the intra and extra articular elements of the deformity. Because in the knee and the proximal tibia, I think not just your intra-articular problem, but your overall alignment is really important if you want to prevent progress of osteoarthritis. And I think we can get really sort of gratifying results in these, especially in the young patients, where if you don't do anything, that knee is doomed. They will end up with sort of an early joint replacement, which is also going to be a problem, or an arthrodesis or something similar. So I think it's worthwhile doing these even quite late. So we've done them quite late, and we can do that in the discussion. Thank you. Okay.
For the presentation? Yeah. Questions on thanks, Dr. John, for your excellent presentation. And now we have a set of questions ready. Any one of you can take them. It is not only for you or Professor Tanna.
Good.
Yeah, this was a 63-year-old patient. Hello, can you hear us?
Yeah, we can.
Yeah, so this was, he came to us at the end of 3 months. What to do now?
So what's his problem?
He has got pain, not finding it difficult to walk.
At least do a CT and find out what is happening there. You have done a CT?
Yes, sir.
Jara close-up dikhana hai us.
हाँ, sir.
So what was the clinical examination like?
Put one more. Next slide.
Any instability, etc.?
The clinical examination was that he had pain and he had virus while walking.
Virus while walking, okay. And any instability on examination and full extension or flexion?
Not my patient, sir. It has been sent to us for clarification from you.
Okay, so
this is the 3D CT, the earlier one. This is the axial curve. You can take the call.
So really,
in hospital. So they would like to know what, how to proceed on this, or if you get a case like this, what to do.
So I mean, the problem is that these CTs are a little difficult to assess. But can you go back to the X-ray if that's possible?
Yeah, go back to the X-ray.
Okay, so it's
this was apparently a fracture medial condyle that was treated probably by a quack, I think. I'm not too sure. And it.
And he's 63 years old.
He's 63 years old, correct.
Okay, so here I think you need to weigh your options very carefully as to whether some complex reconstruction is going to help, or you go straight to a joint replacement if he gets bad enough. Yeah, so I think you need to plan it. Yeah, CT, you need to assess the CT more carefully. If there's a definite depressed part, I would elevate it and plate it. But you need to have a very careful conversation. The problem is there's also some lateral shift here, okay? If you look at the condyles, it's not exactly lined up, but at this stage, because there's no obvious fracture here, it's going to be a very extensive thing to try and correct that as well. Yes. Dr. Tanna, you have any opinions on that? Actually, without a good view of the CT, it's a little more difficult to.
Yeah, I think because I think the CT, unless we have a real close-up, all I can see there is a definite
There's
depression.
A depression on the medial
side.
There
is a lot of depression onto the medial side, but there is nothing on the lateral side, if I can see.
And
or
it's
the other way
more
around.
anterior than posterior.
Yeah, that's right.
That's the only thing I can say. So you could elevate the anteromedial part.
I think if since the patient is young, it will still be worth really elevating it and putting in a plate there.
63-year-old, sir.
So that's why I'm saying this is where you have to make a 63, but is he a healthy, active 63 or a sort of elderly, not
Is
so?
He at 63?
Is he like
Is
like
he,
Dr. Tanna, I would still go for osteotomy. Even
is
if
what I am saying. Is he dancing around? What? You're not dancing around.
No, sir. Go back.
Next. Yeah. This is
So-
what has been done.
So this was done.
Yeah.
Your comments.
Your comments on this?
Is there a virus? I can't see that very much.
No, they attempted an osteotomy.
So this is
and
articular osteotomy?
no, we don't know whether it was a through and through osteotomy or an unicondylar osteotomy. Can't figure it out on this.
Looks like
Probably-
intra-articular, probably.
Probably an
because
unicondylar,
yeah.
intercondylar osteotomy.
Yeah.
There's
was
some
done.
bone graft here as well, I think.
Yes.
Yeah, because it has been really been elevated slightly deficiently, but it has been fairly well elevated.
I think it's worthwhile.
Yeah,
Yeah, fine, sir.
I think he will do well.
Okay, sir. Thank you.
Some questions.
Then there are some questions for the Professor HOLZ. Indications to do a post-operative CT after tibial plateau fracture fixation.
Yeah. Whenever you have any doubt, you should not hesitate to do that. You
Okay.
see, that last case you showed, that was an incomplete correction.
That's right.
The plateau was not completely elevated.
Corrected, yeah.
When you embark for a correction, you must see that at the end of your correction, the axis is aligned. And if you are not sure, you go for a CT and check it.
About the axis correction, I think we do generally with the quarterly wire, which is not as dependable. I have got the about the alignment for the TKR, which I have got it there done spatially, and I feel it is far more dependable than the quarterly wire, which can go slightly haywire. So it is much easier. You can just have that straight rod which can go from the center of the head to the knee to the ankle.
Yeah.
And in this proximal tibia, the alignment is more important than the depression.
Fine, sir.
It's important, yeah.
There is a question for Professor Stannard. They want you to talk on the suprafibular approach in a little bit detail.
To talk on which approach?
On the suprafibular approach, retracting the fibular collateral ligament posteriorly.
Suprafibular.
So the
Osteotomy, epicondylar osteotomy.
osteotomy of
Not
the,
exactly osteotomy, just expose the lateral ligament and retract it posteriorly.
Okay. I know what you're talking about. It's the
to get to the rim. And
JKO's approach, I think.
so no, I think they're talking about Mauricio Kafuri's approach of the femoral condyle osteotomy. So you outline it like what I showed in the slide, and then you take a very thin wafer of bone, and you have both popliteus and the fibulocollateral ligament with it. You peel that back, and then that allows you to open the joint and get a very, very good exposure. When you are done, you put that joint, that bone sliver that's only a few millimeters wide, back with a spiked washer and screw, and it heals very quickly and works very well.
So similar to the medial epicondylar osteotomy on the other side, again, it's
very much
washer with the screw. But I think they were asking about the approach where you retract the collateral ligament and go around the back, which JKO does for fixing his posterolateral condyle. Is that what you're asking about, Rajiv? Uday?
Pardon?
You're talking about the approach where you retract the lateral collateral ligament.
He wants to know what.
Yeah.
He calls it as a suprafibular approach by retracting the fibular collateral ligament
So I think it's a technique.
Put the patient on the not exactly supine, but put him on a lateral position.
Semi-lateral. Yeah. So it's a technique he's described and written about. I find the problem is to get your screws in that direction is really difficult. Even if you can get it reduced and get the plate there, getting those screws angled in the correct direction becomes very difficult. So I find it a little difficult to do it, but he's certainly shown some good results with it. Yeah.
Okay.
And you have to peel the tissue quite a way back posteriorly to get to that posterolateral corner. Yeah. James, have you tried that approach?
it's a very small window.
Yeah.
Yes, I have, and it's a very small window to work in, but sometimes I have used that. And then if I can't see well enough, then I'll go to one of the osteotomies, either fibula or supracondylar. But yeah, sometimes that just working behind and retracting the ligament is enough, but it is a very small window.
I mean, if it's
very small implants only.
Yeah, if it goes more posteriorly, it becomes very difficult.
Yes.
A question to Professor Tornetta by Dr. Naveen Thakkar. During the posterolateral approach and fixation, what is the incidence of postoperative common peroneal nerve palsy?
So I don't do a lot of posterolateral approaches. I tend to work from the front. You know, as Jim has mentioned, it's a really small window if you do that extensile approach, unless you do the osteotomy. It's almost like the fractures that you can get to and require fixation in that back corner, you can't fix them through that approach because they're usually too comminuted and you can see only the comminution and you can't put your plate down distal enough to actually support it. So I think in deference to everybody else, I tend to give up the posterolateral corner a little bit. So, you know, I've got some other methods I use to fix larger fragments, like I'll tamp it up. Similar to the push screw that you saw earlier, I do a little bit of different thing is I put a raft screw across and then I capture it on top of the raft screw with so it's like a blocking screw and that'll hold the back corner up. So I tend to reduce it from the visualization in the front and then fix it with more indirect means because I really just don't like being in the back of the fibula there. It's not a great place to be. It's a tough approach. And the bang for the buck is relatively small. If you get the anterior 80% of the joint back, these patients get stiff. I've never seen anybody who has a little bit of posterior sag in the back have any instability unless they're, you know, a black diamond skier or someone who really flexes and rotates at the same time. So I'm a little less aggressive in the very back corner on the lateral side. So I haven't had any extensive experience. I've done more of those dissections probably in the lab teaching people where not to be than I have in patients.
So I've done quite a few posterolateral approaches for various reasons. There are some fractures which really the posterolateral corner is the only part that's involved. And you need to get there somehow because they are displaced as well as the articular area is shifted out. And I think you have to be careful. There's always a risk of posterior of the common peroneal nerve injury, and you have to be really careful in your dissection. And you should be familiar with the anatomy there. And if you do all that carefully, the incidence is low. I think out of around maybe 12 or 13 fibula osteotomies that we've done, we've had one transient common peroneal nerve palsy so far, which recovered in about 4 to 6 weeks. It took about 6 weeks to recover. James, you've done some as well, so.
Yes, occasionally. I don't use just that approach very often because, again, I agree with Dr. Tornetta that you're just very limited with what hardware you can get back there. But you can use a rim plate like JKO talks about, and occasionally. I think I don't do osteotomies that often either, but it's something I want to have the ability to do for those unusual tough fractures.
Yeah, we have some more questions that we will take later. We request Professor James STANNARD to talk on biological reconstruction of the knee following trauma.
Very good.
All right, hopefully everyone can see that and can hear me. I've been asked to do a very quick talk on the topic that I shared with you all when I was there last year. So if you didn't see those, some of this may not make sense because I don't have enough time to really go through the basic science story of how we got here. But when I have a failed tibial plateau fracture, I feel you need to analyze why did it fail? Is it mechanical? Was it a malreduction? Or is it a biologic problem where you lost significant cartilage or bone and you need to address that? We have focused on those last two areas at Missouri, both in research and now with some innovative clinical approaches. The problem that we have, you might say, well, if I hit one of those patients, I'm just going to do a total knee. But the problem there is when you really look at successive total knees in younger patients, and as someone who just turned 60, I think I'm still young. So when you look at the data, though, from this study that was from Great Britain published in The Lancet, even in 50 to 60-year-olds, you were looking in males at a failure rate of 35 to 38% within 4.5 years, and in females, 20%. So total knees are a fantastic operation for elderly patients for whom they were designed, but it is not as good for younger patients. And if you go younger than 50, the problem, I believe, gets worse. So we were looking for what's a solution. And our scientists at Missouri came up with a new way to preserve osteochondral allografts. And this is some of the different published information on it. But bottom line is, we thought it was just letting us preserve it for longer to make it easier to get patients scheduled. We learned that it did quite a bit more and became very important. And what was really important was not that we could go longer, but if you look at this slide, I will orient you real quickly. Green staining cells in cartilage are alive. Red staining cells are dead. And so here you see on day 0, just a normal control patient, the entire articular cartilage just about alive. If you look at the normal way that tissue banks have been preserving this cartilage, at day 28, you can see there's a lot of dead cells in this superficial portion of the cartilage. There are some alive deeper. By day 56, everything's dead. Day 70, everything's dead. If you look over here at the new way of preserving it that was developed by our scientists, you can see at day 28, it looks very similar to the day 0 control. Almost everything's alive. Even at day 56, it's really pretty good. It's much better than the standard of care at day 28. And so we started to realize we weren't just getting an improvement in terms of the number of days we could wait, but we were getting way more live chondrocytes. So we ended up publishing that in this article, and we compared 50 grafts that were preserved. The Musculoskeletal Transplant Foundation bought this technology, and it's called MOPS, for Missouri Osteochondral Preservation System. And our grafts at an average of 44.2 days, oldest was 56, had 96.7% of the chondrocytes viable. VCD is viable chondrocyte density. We compared it to 26 from a variety of other tissue banks using the standard preservation, and their viable chondrocyte density was only 48.4%. We believe from other studies, some of which we've done, some have been done by others, you need 70% alive for it to work in the long term. So you can see that from the other tissue banks, we were getting most of them not with enough live cells for this technique to work. We also looked at other ways to try and make this work better. And one was, how do we get the bone to incorporate better? And here we used bone marrow aspirate concentrate and dripped it on the grafts. You can see my fingers holding a femoral condyle graft. So after washing out all the cells with pulse lavage, we take this bone marrow aspirate concentrate and soak the cancellous bone with the recipient's cells. And this is a slide that just gives you an idea. At the top here is a bench study we did. A was the bone marrow aspirate concentrate. C was PRP, and E was just saline. Neither C or E have any cells in them, but you can see where we use the bone marrow aspirate concentrate, we have a number of pluripotential bone forming cells. We published that bench study, and then we looked at in human patients how it would work in terms of incorporation, and that's in the table that you see there. We found at 6 weeks, 3 months, and 6 months, in all cases, there was a statistically significantly higher incorporation, and that was also published. So that was kind of a game changer for us. We also found that size matters. We know from the tumor literature that if you put a really big, thick graft, it'll look great when you put it in, but it will eventually die and fall apart because the creeping substitution cannot get through a thick graft before it collapses. So we were trying to find out, we got our engineers to look at what's the proper thickness to be strong enough to allow us to walk on it after a little healing time, but to be thin enough to allow for the creeping substitution. And what we found was 6 to 7 millimeters is kind of that sweet spot where you can get the creeping substitution to actually work before the graft dies and collapses. So this is an example of what we do. This is a femoral condyle. We also felt stability was very important. So we cut a keel here, borrowing from the total joint technology. And you can see how we match it with the graft. Very thin, about 7 millimeters, half of it cartilage. And then we have this keel that we've custom cut in. This is what a tibial plateau looks like. Same thing. We've got a keel to help with stability. Very thin graft. Those are my fingers holding it. Meniscus, articular cartilage, a little bit of bone. We just published our clinical outcomes in May in the American Journal of Sports Medicine. And I believe this is the largest study, single study ever published. 194 patients that had 1 to 4 year follow-up. Mean was 30 months. And what we found, almost 2/3 of our patients had bipolar grafts, which have been very unsuccessful in the literature in the past. Grafts, not the MOPS grafts. We had 40% failure, 60%. And I'll show that in just a moment. So what we found was the MOPS grafts had a significantly lower rate of a need to revise to another graft because the first one failed, and a significantly lower failure rate as well. Very importantly, what we found is that many of the patients who failed using our grafts were patients who did not comply with the rehab protocol, which really goes for a whole year and requires them to do certain activities or not do certain activities so that the grafts don't fail. So you have almost a 7-fold higher risk of failure if you don't comply with the protocol. Those who did comply with the protocol had less than a 10% failure rate with our MOPS grafts. So that's starting to get into a number that we feel is encouraging. This shows you the pain scores, pre-op, 1 year, 2 year, 3 year, and 4 year. And you notice it keeps falling all the way through 4 years, and it's down below 1 by the time we get to our 4-year patients. These are other patient-reported outcomes, the International Knee Documentation Committee's IKDC, and then SANE and PROMISE. And you see the same thing. They start at very low levels of function because they weren't doing well preoperatively, but the IKDCs are almost 90 by the time we get to year 4. So it's interesting that they don't top out after 1 year or 2 years. It keeps getting better and better in these patients, many of whom have had years of problems. This shows a Kaplan-Meier survival curve. And I just would really encourage you to look at the bottom here, the MOPS graphs. And what you see is that you get most of the failures in the first year. By the second year, it's dropped to 89% survival. And then it held at 89 for the 3rd and 4th year. I have no doubt it'll slowly tail off over time, but it's very encouraging that if you can get through that initial 1 to 2 years of true incorporation of the graphs, they seem to start to hold steadily. So looking at a couple of cases real quickly, just to show you examples of tibial plateaus that we've used this on. This was a case that was forwarded to us by Joe Schatzker. She had severe valgus instability and severe pain from this fracture. And I don't know if it was poorly done or they had just lost tissue. It was done in the Philippines when she was there as a tourist, normally a very active young lady. This shows her walking in our clinic. And you can see she has to use 2 crutches. Part of that's due to the valgus instability, part of that's due to pain. So what were treatment options? Her cartilage was gone in the tibial plateau for sure. I was worried about her femoral condyle as well because she'd been dropping into that hole for 2 years, previously active from Warsaw, Poland, in great health otherwise. So we evaluated her, had her ready to come as soon as we got a graft approved, basically on standby to go to the airport and get to Missouri, which is a long way from Warsaw. And this is an example of the graft that was put in. The things you have to consider and have to make sure you have are stability, alignment, and the remaining articular cartilage must be in good condition in order to do this technique or must be replaced. This is what her tibial plateau looked like. So you can see this was not in good condition and needed to be replaced. And we need some bone to go with it. And that's what her femoral condyle looked like, or I'll show you pictures here. You can see it was pretty beaten up. And so if we only took care of the tibial plateau, I was concerned still have significant pain from that femoral condyle. So what we did was we cut off the tibial plateau, and I always use fluoro at the back there so that I don't damage any critical structures. And you can see what we cut out, and it was just not a good looking tibial plateau. This is cutting out the femoral condyle damage. That's what we took out and what we put in. There's the graft going in. and here's your tibial plateau, and we put in a meniscus and a plateau. These little sutures are attempting to reconstruct the meniscotibial ligament, which is really important. And we quickly checked that we had alignment right. The alignment rod's not that accurate, but it gives you an idea at least, and it looked like we were in pretty good condition. And this is what it looked like arthroscopically at the end of the case. You can see a beautiful femoral condyle, meniscus, and tibial plateau. Now, it's easy to have it look beautiful at the end of the case. The trick is, can it still look beautiful a year later? This is her at 5.5 months post-op. At that point, she was walking with no ambulatory aids greater than a kilometer at a time and had great pain relief. This is 2 years post-op. This is a video that she sent us. She's a very, very grateful patient, and it was near the holidays. She wanted to show us that she'd become very active, no problems with walking, doing other sports, and was just very, very thankful for everything that had been done. This is our most recent interaction with her 4-year follow-up x-rays, and she let us know that she'd become engaged when she was in Colombia. Her fiance came with her for the surgery and asked her to marry him. And she let us know they were now finally going to be getting married, and did. And then they were going to come visit us this year in April, and then the pandemic hit. So hopefully they're going to come and revisit the place where they became engaged. But she's doing phenomenally well, and it's been a really good story. Here was another case, and this patient was in terrible condition. More than 20 surgeries, everything you could think of had been tried. He had a terrible crush injury. He was going to go for an amputation above the knee if we couldn't do anything for him. And I told him that this is a really tough one. We can try, but you have to know that the failure risk is high. Arthroscopy demonstrated severe loss of articular cartilage. We went for a biologic joint replacement with some reamer irrigator aspirator bone stock to give us some bone and some biology, and a very slow recovery process. So there's the new grafts in place radiographically. They look good, but again, it's easy to have them look good at the beginning. You got to get it to work in the long haul. Here was his first walking in 4 years with no crutches, and this was at about 6 months, and really doing well. This is again 16 months out, how it looked. He's working on a 0 runner and elliptical. He just crossed 2 years. Phenomenal outcome measures so far. All the graphs are looking good so far. So very encouraged. That's how it looked at the start. That's how it looks at almost 2 years follow-up. Last case real quickly, a 57-year-old. Now this patient could have had a total joint, but she was extremely active. So a friend of Mark Lee, who's a really good surgeon, said that her cartilage was gone. Is there anything we could do? So she came. This is what she looked like. Severe valgus. You can see her walking is really not good, as you'll see real quickly from this video. This is a lady who was a marathon runner and just terrible. So again, I told her that this is a rough condition. If it doesn't take and work, you're going to end up needing a total knee. But we did an osteotomy, and then we went to replacing that cartilage on her femoral condyle, and that's putting it in. And then we did the same thing with the tibial plateau, again, under fluoroscopic control. This is hand cut. That's what came out. That's what went in. And that's putting it in. And here's how we looked at the end of the case. This is her walking. You'll see that valgus is really gone as she walks, really with no problem. And she's actually back. She's crossed over 2 years as well, and she's back running now. So very, very happy overall with how she's doing. So what would I tell you about this technique? And I'd need much longer to really explain all the science. But when it works, patients can achieve a very high level of function. Back to military combat duty, return to competitive baseball, running 5 and 10K races. When it works, competitive cheer and gymnastics. When it works, it really works. But when it does not work, they may be a little worse off than when you started. And they've gone through a very big operation. So they have to know that if they're going to do this technique, because it does not work every time. You have to coach and counsel your patients carefully and select them carefully. Pain is not an indicator of a healed graft. You have to make sure the patient knows that and doesn't start doing things too early because their pain is gone. So in summary, I would tell you for salvage of a failed tibial plateau fracture, you need to look at the cause. If the cause is biologic, we now are getting some new options that are going to be available to everyone if your country allows you to place live tissue grafts. Thank you very much. And I also want to thank you all for allowing me to participate. I unfortunately have another conflicting event that's coming up, so I'm going to have to sign off and miss the discussion part, but I really appreciate joining you, and hope the rest of it goes very well.
Great. See you, James. Good to
Thank
see
you. Bye-bye.
Thank you, Professor Stannard. That was a dream presentation. We have received no questions for you from the audience for your dream presentation. So any faculty members want to ask any questions to Professor Stannard, they can ask.
How many cases you have done, James?
Gallery. Dr. Tanna has asked.
How many cases you have done up till now?
What do you want to see the speaker?
Not all the speakers. Discussion. All the speakers. Dr. Stannard.
Can you hear me? Can you hear me?
Yes, yes, sir. Yes, sir. We can hear you.
James, how many cases you have done up till now? And how many of them you felt they were really bad ultimately afterwards?
Not sure if he's still
I
there.
think he may have signed off. He was he had another conflict.
He was leaving, so he may.
No, he's there.
There he is. There he is.
Okay, he's there.
Sorry, I lost my internet for a moment. So you were just asking if there were any questions, and the internet crashed.
Yeah, there has been a question from Professor Tanna. Sir, you only ask him.
How many cases you have done, and how many of them had a real bad failure where you really felt that the patient were worse than when they started off?
I'm sorry, can you repeat again? Internet's not very good right now.
How many cases you have done where you had failed miserably, and then it's what I'm asking. Basically, out of how many of them failed miserably, percentage-wise, approximately?
So with the MOPS graphs, our failure rate now, we just published that big series. We've now done another year worth of patients because it takes that long to go through publication. Our failure rate now with the MOPS graphs for every case of MOPS graphs, whether they stayed with the protocol or not, is down to 13%. And that's out of probably 250. No, I'm sorry, MOPS only about 200. And if they stayed with the rehab protocol, it's down around 9% or so. So the number is improving. Part of that's getting better at selecting the patients. We now make sure that a psychologist interviews them because some of these patients just won't do the rehab protocol and they will fail if they don't. So it's getting better, but when they fail, they really do fail.
Terrific.
Professor Stannard, we have received another request from the audience. They have loved your presentation very much, and they would like you to be back whenever we call you again.
I would love to join you either electronically or hopefully in person if we can get past this pandemic at some point. But thank you so much. I really appreciate it. And I'm so sorry that I have another commitment, but thank you for allowing me to join you this morning.
Perfect. Thank you.
Bye-bye.
Bye.
Next question. Questions. Presentation.
He's going. He's already going. Already started. He's already started. Now even video I will stop.
All right. So I'm going to talk a little bit about techniques in nailing. I was asked to talk about suprapatellar nailing, which I don't do. And I can explain to you on the way through why that is. So these are my disclosures. Again, the devices that you see, I've designed, but the principles are irrelevant to the design. So this all came about with problems with proximal fractures that were reported back in the 90s when I was just starting practice. And no one could seem to solve that issue. And the problem was basically is the tibia is big at the top, and even if you got the nail down, you tend to shift like in this example here because there wasn't great stability. So it's related to having a good portal, locking while you reduce. There are some device problems. The Synthes nail in particular has a bad bend to it. It's now curved, but it still has the same dimension. So it tends to shift you a little posterior, as Brad Henley has shown. So, in that time frame, a couple of us were experimenting with techniques, me with extension and Chris Creddick and Dean Cole using blocking and polar screws. But this is an example of why that Synthes nail is not great, because anytime the bend is past the fracture, it's going to give you posterior translation. So the problems that were common at that time point were valgus because, as you know, anytime you put a tibial nail in a fracture, the nail will sit against the lateral cortex. So if the portal is a little bit too medial, the nail is going to go this way, and that's going to shift you over into a valgus position. So you must identify a portal that will run right up against that lateral edge. So it's a little bit more lateral, and that will get you down the shaft and keep you more straight. The other problem is flexion. When we did these fractures and flexion on fracture tables, even with distractors, when you flex the fracture, you would end up, when you flex the knee, you would end up flexing the fracture as well. And there were a lot of x-rays back in those days that looked like this. and as you know, a procurvatum deformity in the tibia is just awful. So the solutions for this, to me, were fairly straightforward. Is get a proper portal. You want to make sure you can see good AP visualization to do that. And then if you hyperflex the knee and there's anterior angulation, I do the case in relative extension. And if there's posterior translation, I'll add a blocking screw. So that's a pretty straightforward way. And if you run that algorithm, which I'll show you, you'll be right all the time. This is the initial portal location kind of on the front part of the tibia that Kuncher used actually in extension. And that other people use in flexion. And that's not a really good portal because you're going to drive out the back of the tibia and give yourself an anterior deformity. Jim Carr described this more superior portal that'll run a little bit more down the shaft of the tibia. And that's the portal that I would recommend using. So we did a little work back then in looking at the anatomy and the surgical anatomy to say, is this a safe area to be? Because this is about the spot you want to be. So if you look at where the center of the tibia is, it's a little bit on the lateral condyle and it's about a third of the way back. So it's in the meniscus is where the center of the tibia is. So you can't be right on it, but you want to be close to it. And this is basically in the intermeniscal ligament. It's a safe place to be, and I don't have a lot of knee pain when I do this portal, but you've got to be precise about it. So it's an intra-articular portal. It's on the superior surface. And if you align it with the IM canal, it's about 9 millimeters lateral to midline, a little bit lateral to the center of the tubercle. So this is the sweet spot right here. Radiographically, it's the black line. So on average, it's just medial to the lateral tibial eminence. And on the lateral view, it looks like it's in the joint because it's between the articular surfaces of the joint. So this is just a very old case. I always keep this in. I think it's about 20 years old now or more. You can see this was the initial place where if you just kind of made a little incision and you put the thing down, that's where you ended up. And that's not a good portal. You've got to shift all the way over here to right near the tibial eminence. And on the AP, it looks like it's in the joint. And you can see that that's the right spot. So this is my algorithm. I get a lateral inflection. If there's anterior angulation, then I do it in relative extension. If there's posterior translation, then I'll likely use a blocking screw, although more of these that I do, the less blocking screws I do. And if I have both problems, then I can use both solutions. And that'll solve all of your proximal tibial issues. Now, this is probably the biggest mistake I made in my career is that image on that left side. So that was the image that accompanied the cases that went with the initial report of semi-extended nailing. This was just what my artist at the time used to show the deep incision. But the image on the right is a 22-year-old image. That's the biggest incision I've ever used for this technique. And you see that's an open fracture. And really all I do is make an incision right over the patella. And then the deep incision goes around the patella and around the patellar ligament. And that allows very easy lateral subluxation of the joint. And that doesn't lead to a lot of problems. So this is what it, all right, it's not playing. Okay, sorry. Not sure why that's not playing. But basically what you're doing is you're working underneath the patella. So you can keep this in relative extension. If you're perfectly straight, you actually can't get the right portal. You have to be flexed about 25 degrees to get that portal. Otherwise, as you extend, the trochlea becomes a little bit more prominent and you end up being in that area that's too anterior to the tibia. So here's just an example, pretty proximal fracture. Here's where I want to go. You can see there's a fracture at the level of the joint. So we're going to fix that first. So we put lag screws in after we reduced it, percutaneous, just to stay out of the way. And we left the portal for the nail open. So that's what it looks like. This is where, and because there's a fracture, I use a guide wire. Typically I use an awl, but here's a guide wire running down. You want to be parallel with the anterior part of the joint. This is the incision. It's not a big incision. The cannula goes underneath the patella to protect the trochlea groove. So again, it's about a 4-centimeter incision. It's not a big incision at the skin. And then this is hopefully, no, that's not playing. I apologize. I'm not sure why these aren't playing because it played when I ran it. But this just shows the reaming. This was the first cannula that we had. It was a custom-made cannula. And again, having that 20 to 25 degrees of flexion or a little bit more allows you to get the proper portal and the proper trajectory. If you're in full extension, you can get only one of those two things, and I think that that's problematic. So here, oh, looks like that's going to be a problem. We drop the nail, we lock the nail. I'll just go through this. So this is what the locking looks like. Again, we put these screws in an area so that there shouldn't be any issues with with getting them in. And you can see them underneath those locking screws in good alignment overall. Closure is pretty standard. It's just like any other arthrotomy. This is the final x-rays. Now, blocking screws, the idea of a blocking screw is that when you put a nail in, it's going to ride against the posterior cortex. Just like it rides against the lateral cortex, it rides against the posterior cortex. So if you put a nail in, it's going to do this, and it's going to shift your canal, and you're going to end up with a flexion deformity, which is terrible. So if you put a blocking screw here, that tightens up the canal, which means your nail can go only here, which is going to give you proper alignment. So that's the idea of a blocking screw. It's a posterior substitute cortex. So this is that same case. It's about 20 years old with one of the earlier blocking screws I used. So here you can see the aul's in place, but there's posterior translation. I'm afraid that if I just ream here, I'm going to end up with anterior angulation. So there's the blocking screw that was placed with the aul in place. And you can see that displacement of the anterior cortex. And now the nail going through in front of this, then you can use the nail to flex that fragment, get it into the distal segment. And now you can see we've diminished that to a couple of millimeters. Pretty good alignment. You can also see there's a little bit of angulation here. So if you look at this, there's just a little bit of an angulation, and you can adjust that to get rid of the angulation and accept a little bit of translation. So by rotating the nail, you can correct that, and now you get perfect alignment with a couple of millimeters of lateral translation, and that's a good trade to make. Now, in terms of stability, blocking screws will give you some support. This is sort of a case that was done in my place years ago where you can see they had all kinds of problems. There's a flexion deformity there, and they put in blocking screws to try to protect and gain stability, but it was done too late. It wasn't done to block the translation. It was done to give extra support. So you can put in screws around the nail to give yourself extra support, but that's not going to help correct the problem. So the other option is to fix the locking screws or use an end cap for locking, or some other way to lock the screws to the nail, because that'll help a lot. And this is just an example of showing a nail that has some screws in it that thread into the nail. And there's a lot of different ones on the market now that do that. So here's an example of a 36-year-old proximal fracture. You can see it extends up into the joint. Here's the fracture that goes into the joint. There's the CAT scan showing it's a multiplanar fracture, but basically it's all together. So in this case, I'm pretty comfortable nailing this. We put in some AP screws that are out of the way just to hold that coronal plane fracture, and then we just go with a standard nail like we discussed. So you can see it's way up on the superior surface. It's not in the anterior area, and that's going to give you really good alignment. So again, a little translation I don't mind. I just don't like angulation. So here it is post-op. Here it is at 8 months, and that patient went on to do very well. The other problem that we see is gapping. So, when we do these nails in hyperflexion with the foot on the table and you're tapping it down, the fracture tends to compress. When you do them in relative extension, though, you can get gapping. So you have to keep in mind that when you're driving the nail down, even if someone's holding the foot, when you're in relative extension, you're likely to gap the fracture open. So I always view the fracture site when I do my final impaction. If it gaps open, I overseat the nail by the amount of the gapping, right? So you can see I overseat the nail by the amount of the gapping. Then I lock it distally, and then you can back tap to get that back to a normal position. So you want to keep that in mind, because that is one of the definite problems that happens with extension nailing. The other thing I think is good for relative extension nailing is when you need to see the AP and lateral image at the same time without moving the limb, because you can't really do that so well. So a lot of these oblique fractures I tend to do by doing percutaneous clamps, and doing them in relative extension gives me a real advantage to see that I haven't lost my reduction. So here's just an example of clamping that in place with a percutaneous clamp and then driving the nail down. And you can visualize this in the AP and lateral plane during the entire case. And that makes it a very handy technique to do for these distal fractures. And you got to be aware that these are often associated with these posterior injuries. So here you can see a posterior malleolar injury with impaction. There's a CAT scan of that injury. So for these, what I tend to do is I tend to go to the back, do a perfect reduction, and then you can see I put these screws in off center to allow myself then to nail the patient later. So then we come back from the front and do a nailing adjacent to those screws. So this is a recent case that kind of had all these things. So it's a segmental fracture. I did it in relative extension. I used clamps and I actually had to back tap it. So I like to show these, just something recent. So here you can see one of the fractures being clamped, and there's our reduction. And I ended up putting 2 clamps on. So if you do these carefully and you place these clamps in an appropriate way, they just stay on the whole case. And you can see here, there's really no risk to the soft tissues if you place them through very small poke holes in the right place. And you see about 25 degrees of flexion. Here you can see those clamps from the other side. No tension on the skin whatsoever if you do these the right way. And basically now it's a sawbones case with a 25-degree amount of flexion. So there's our guide wire going down right on the superior surface. And you can see the nail passing, clamping, getting reduction of the proximal, and then the distal segment. Now, in final impaction, you can see that distal fragment gapped open. So now I'm going to go back to my thought process, just over impact it, lock it distally first, then back tap. And now you can see we get compression of that fracture and a very good alignment for that comminuted, that segmental fracture pattern. How about this one? I think you can combine nail and plate constructs pretty often. This is sort of extreme nailing, but here you can see a joint impaction, but you can go ahead and take care of that. You can see the initial frame that was on, it was a grade 2 open fracture. Here you can see that anterior injury that's going to have to be reduced. So I went with a nail plate construct. So I did a small open, get the fracture reduced up top, and used lag screw and anti-glide plating. You don't need a big plate for these. And this is going to leave room for my nail to pass in front of this area. So I'm also going to put a blocking screw to make sure I tighten that canal. This is a guide that I use to place the blocking screw. So it'll fall off the top of an awl or a guide rod. And it'll actually put the screw exactly behind where the nail will be. And then here you can see that blocking screw is in, and then a percutaneous clamp to help reducing the AP plane. Now I'm passing the nail in front of the blocking screw and around the fixation for the plateau, getting that across. And here he is at 110 degrees at 2 weeks, the AP in the lateral with good alignment of the joint and that, and at 6 months goes on to have an excellent result. Here's an example of a patient that was sent in late. The AP and lateral x-ray of this patient, unfortunately, are on the same film, so that's not ideal. He had a big skin bridge that was dead. He was about 3 weeks out. So we ended up having to excise the skin. And this is another technique I like, and I'll show you a few other things, which is I like mini plates used as a clamp. So the clamp holds it on. Unicortical screws in the anterior cortex can hold that thing reduced while you go on and do the case. So here you can see clamps holding it together and the mini frag plate. And then we nailed that, took the plate out, got soft tissue coverage, and this guy actually disappeared and never came back. So I don't know, I mean, he may be in your neighborhood now. Hopefully I'll never see him back, but this went out and it came over pretty good. For open fractures, I think this is a frequent flyer I had. So you can see he's got a healed fracture. He broke through that healed fracture, an ankle fracture. But when I tried to nail him, I basically couldn't hold him aligned. Every time I dropped the nail, something happened. So I went and just put on some plates adjacent to it to hold it reduced while I reamed, so I could reopen that canal in a way that made sense, and then nailed it and removed those plates. He went on to do well. The final thing I like to show you is something I call intracortical screws. So we're just writing this up. I've been doing it for about 5 or 6 years. Really did it out of desperation the first time. But if you look at the thickness in patients' tibia in the midshaft, you have about 12 millimeters at the front, somewhere around 6 on the sides. And oftentimes you'll have like an anterior cortical fragment that's free and it's attached to the anterior soft tissues. You don't want to lose that connection, but it can make open fractures hard to close. So you can actually fit, 2024 and sometimes 27 screws inside the cortex and still leave room for your nail to go around those screws. So this is actually one of the first cases, a 24-year-old with a grade 3C that required an arterial repair. And when I was doing the case, in the operating room, I put it in a frame, but I couldn't hold that fragment of bone stable. So I ended up putting an intracortical screw in with the frame, and you can see that held that fragment stable. And you can see on those views that it's out of the way of the nail. And then I went on and nailed it with that screw in place. And I said, geez, that's a pretty good idea. I might want to use this again. And again, the semi-extended technique was also out of desperation. So all these innovations come from a patient need. So here's the patient post-op at 161 days. His rust score was low. I dynamized him. I do believe in dynamization. I've had good results with that. So here you can see a little bit of a gap. And here he is with a rust of 10 at 334 days, went on to union. Here's another example. This is a 29-year-old who had a femur and a 3B tibia. And the same problem. So, he was wide open. So we clamped everything together to put the nail in. But then when you took the clamps off, that anterior shell of bone, which is attached to the anterior compartment, was just displacing. It was really making it hard to close. So he had 3 loose fragments. So he ended up with, a bunch of intracortical screws holding all those fragments down. And you can see everything is really well aligned. We got coverage for the patient. And then here you can see over time, you see the close-up of those screws. They don't have to go all the way through. They just have to get about 3 or 4 turns on the opposite side. So you drill them, you over-drill them, and then you tap them because it's very dense bone and you can actually pop the heads off. But you can see it holds it in very good position. And here's that same patient now about a year later after dynamization, again, well healed. So in summary, the semi-extended technique is based on portal and trajectory. You have to have the right portal and you have to be parallel with the anterior surface of the tibia and down the center of the tibia. I use a limited ream or an unreamed technique. I like semi-extended nailing, not the suprapatellar nailing, because that puts you in the wrong place or the wrong trajectory. Use blocking screws for proximal fracture when you need them. Liberally use clamps and mini plates. Look for gaps to make sure you back tap if you're in extension. And I like the idea of multiplanar lock screws. Thanks very much.
Yeah. Yeah, no, I have asked. I've told Ajit. Thank you.
Dr. Paul, that was a brilliant presentation. And quite a few people have already sent me the request questions. And they want to thank you for this intracortical screw fixation, which they have heard it for the first time. Thank you very much. I think we have a request from Dr. Ajit to ask you some, he wants to ask you some questions. Ajit, yours.
First and foremost, fantastic talk, Professor. Just wanted to know, could you clarify exactly the difference between your semi-extended nailing versus suprapatellar nailing?
Yeah, so, the first case of this I ever did, I was actually a resident and I was on a chick table. You guys remember the old chick tables, right? So I had this big bar coming over and I had a patient with an open tibia and a femur. And we did an antegrade nail, with a femoral traction pin in the femur. And the patient started to decompensate. And I wanted to just get something down the tibia really quickly. And I was in extension, right? Because I had the leg held up in extension. And the patient had an open wound that extended up pretty proximally. So I basically did a medial parapatellar incision, moved the patella out of the way, and then nailed it, through the right on top of the trochlear groove. And again, out of desperation, we just got something down, 1 screw on each side, and then had to bring the patient back. But they did well. And on the basis of that, we had access to a morgue in Brooklyn where I worked. So I went to the lab and I said, geez, I moved the patella out of the way, but why can't I just go behind it? So I did I did about 50 cadavers back then. And I used to do a lot of cadaver studies to figure out surgical technique. And when I went behind the patella, the problem was it was very tight. And if you look at where you want the portal to be, you want it on the superior surface of the tibia.
That's right.
So if you have the knee in extension, and this was published by Mark Lee and colleagues from Sacramento, because I had talked to him about it and they did a cadaveric study looking at it. It's in JOT. And basically, if you look at it, the way the trochlea, if it's not malformed, is that if you're in full extension or very close to that, if you want to get to that proper starting point, you're pointing straight back toward the back of the tibia. So you have the option of being in the good starting point with the wrong trajectory, or you can be more parallel with the tibia, but then you're coming in distal right underneath the patellar tendon, which is the old Kuncher portal, which frankly, he did an extension, just with an awl. Same place, right? You didn't need to have me under the patella to do that in relative extension. There's a video of him out online you can find doing that. So to get the proper trajectory and the proper portal, you have to be in about 25 degrees of flexion. And to do that puts too much tension on the patellofemoral joint if you're under it without doing a release. Now there's multiple other methods published. There's a medial and a lateral parapatellar tendon approach that have been used, where you stay sort of extra-articular and sort of push the patella out of the way a little bit and fight your way through. That also seems to work. But the true suprapatella is a very difficult approach if you want the proper portal and proper trajectory. And I would refer you to look at the original article that came from Tampa, because Roy Sanders is a very good friend of mine. I actually helped edit that article for him. But if you look at those articles, anyone who's done suprapatella and they show you a proximal tibia fracture, I defy you to find one that's anatomically aligned like basically all of mine are. And those are the ones in the article, right? So they didn't pick the worst one to put in the article. Right. And when you look there, you'll always see a little bit of flexion, or you'll see a nail that's really far anterior that it's hard in that area of the tibia to understand how deep you should be to not bother the patellar tendon, because it's an oblique surface. So a lot of times people leave them long. Now, if you're doing a distal fracture and you want to go behind the patella and use that anterior portal, I think that's fine. That's not going to be an issue. It's just a different spot, and you've got to drive the nail down further to not sit behind the patella tendon. But that to me is a more reasonable time to use that approach. But I don't like it for proximal fractures. And, I've looked at my knee pain. I took those slides out of the talk to be a little faster, but we published on our knee pain for like a hyperflexed poke hole technique versus the semi-extended technique that I showed you. The patients with the semi-extended technique had more intra-articular pathology, but they didn't have more knee pain, prospectively evaluated. So, once we looked that up, I became very comfortable with using that technique for more cases. So now I use it for the proximals and distals. I still like a hyperflex position for mid shafts that are stable, so I can compact the fracture when I nail it. But I think that's sort of my thought process.
Thank you.
Dr. Paul, thank you. We have another question from one of India's senior most trauma surgeons, Professor Kulkarni. He wants to know, what are your indications for a fibular osteotomy?
I've never done a fibular osteotomy, and I never plan. My indications are slight psychosis and being a little nuts.
Professor Tanna, sir, you have the largest experience in interlocking nails. Any questions from your side, sir, which could be educative to the audience also?
No, I mean, I think, I've seen a lot of all of your work. It's fantastic stuff. I mean, you guys are,
I've got a couple of questions for Paul. One is, do you always use screws as polar screws, or do you sometimes use K-wires or stem wires?
Yeah, occasionally I'll use the drill bit to hold something in place and then remove it after I've locked.
Okay.
But you've got to be pretty close to do that, because, the bending stress is the radius of the fourth power. So, if you have a 4-2 screw in there, you can bend it. So I would say though that, with more use of clamps and a little bit more experience with the techniques, I tend to use less blocking screws than I used to.
And you mentioned Roy Sanders' paper on the suprapatellar nailing. They actually, in that paper, reported less sort of anterior knee pain with that technique as opposed to conventional nailing. What's your thoughts about that?
Yeah, so if you look at that paper, they had a 9-quadrant little area, but it was on top of the patella. So that's where the incision, right near the patellar tendon is where the incision is for regular nailing, but they didn't do real knee scores in that.
Okay.
And I love Roy, but his patients, he makes them feel pretty optimistic, I think, when they're in the office. And people don't want to disappoint him. I mean, I don't want to disappoint him, so I'm sure the patients don't either. But his incidence of knee pain is actually lower than a survey of my patients' contralateral knees in my clinic. So I don't really know what to make of it.
And Paul, if I can ask you this about the proximal tibia fractures. about the proximal tibia fractures. Those who are not very conversant with the way you are talking about or a suprapatellar nail, an ordinary minimally invasive plate in a normal anatomical alignment which is achieved. Is there any problem with that?
No. So if you're talking about an extra-articular or minimally intra-articular, very proximal tibia where you can do either technique.
Yes.
So I prefer nailing for two reasons. So also we did a randomized trial that was reported at the OTA last year. We had 16 centers. It took forever because everybody had their preferences. So they didn't randomize a lot. We had only 70 patients, but it trended towards a better result for the nails. The reason I like nailing it is, one, I know that the knee pain is a relatively low rate. Two, I know I can get the alignment perfect. Three, it's a load sharing device so they can walk earlier. But four, maybe more important, I'm outside the zone of injury with my incision. So I like being outside the zone of injury with the incision. So I strongly lean towards nailing those. Now, that said, I don't think there's anything wrong with doing a plate. I think that the patients won't walk quite as early. And there is probably a little bit higher risk of complications from, having something on the lateral side and underneath the compartment. But I don't think there's anything wrong with the technique. I think if that's what you do well, I wouldn't change it at all.
Yeah. Dr. TORNETTA, what is the incidence of cartilage damage in suprapatellar nailing?
So Roy did an MRI study that showed they didn't have any damage. My first 26 cases, I had 2 patients that I scuffed the cartilage a little bit, right, when I first started. But you got to remember, when I first started, all the jigs were different size than the nail. And, now everything is smooth all the way up and there's cannulas that you work through. Now, I don't nail through the cannula. I just ream through the cannula. But there are companies that make a 14 millimeter cannula that you can actually put the whole nail through to avoid that. So I think if you do it carefully, the incidence of real trochlear injury is exceedingly low. But you got to keep in mind that if you have an arthritic patient, a patient that doesn't have a lot of flexibility in their patella, that you probably, if you're doing suprapatellar, you're probably gonna have to extend the incision down the medial retinaculum, probably down as far as the MPFL or a little further, to lift up and give yourself a little bit more room so you don't have too much pressure. Which is, again, if you do the whole arthrotomy like I do and lift the whole thing out of the way, it's not a factor. So I would say it's very low. And I don't have, in my practice, people really with patellofemoral pain from that approach. So I'm pretty comfortable with that statement at this point. Early on, that we did make a few errors.
There are some of the surgeons in India who have made it on an Indian nail which has been manufactured for a suprapatellar nailing, and they recommend first I think before you start the nailing, you do the inflation of the joint. You put in a saline and inflate the joint. Then the whole joint becomes much more lax. You have any experience or anything about it?
Yeah, that's interesting. I haven't done that. I think any way that you can make more room makes sense. So if that floats the patella a little bit and makes it easier to slide through, that sounds a good idea.
And obviously, once you do the suprapatellar nailing, you will need the reamers also, which are longer, because you will not be able to.
Everything has to be right.
It has to be longer.
Yeah.
Right. I had custom stuff made for me in I think it was '92 to start doing this, and then they wouldn't commercialize it because they thought no one would ever do it. So it's
if I can suggest to you, in India we have made those suprapatellar nail at a much more cheaper, probably 1/10 of the cost which you have it in America, with the nail and the reamers and everything which has been done, which has been copied. And they are of the very good quality, which I understand.
I have no doubt.
It's a sales pitch, Dr. TANNA. Okay.
I'm trying to just sell it to America. That's what I'm asking.
I know, that's right.
It's a hard nut to crack. Yeah.
I'll start with the
Dr. Paul,
thank you.
Thank you very much. It was an heartening presentation. By the way, is this your first webinar to India?
No, I've done some from the Learning Center for the Academy, and I think I have another one. Coming up in August.
Yeah. Okay. Good.
This is first.
But this is your first. The other one is coming later.
No, no, you say it is.
Some of the Learning Center courses, I think, have been simulcast to India, but it wasn't like I saw any of the people over there. It's a lot nicer to see you all.
Okay, fine.
Paul, Dr. Rajiv wants you to say it is the first so that he can get the
You know, this was my first one to India, and it's fantastic.
Yes.
Now you said the right words.
That's right.
Just edit out the rest, you know.
Sir, we go for cases now. Professor Tanna, sir, you start with your case presentation.
Sir, I'm going to.
Yeah. Now here is a 60-year-old man. 2 days after the surgery, he comes over. The preoperative X-ray, the operating surgeon didn't give it. This is how exactly it is. Now, how do you proceed with this? He had done this fibula plating, and obviously had given him a foot drop. This is 2 days after. It was now from a very average center in India, in the interior. He came to one of the 5-star centers where I work. And now he came over here, and then obviously the things were not all right. So how do we proceed, if I can ask any one of you?
So does he have a pre-op CT, which
No. Okay. I'll tell you, John, you will be aware of the situation.
Yeah, I know. We see a lot of
Professor HOLZ to take this question.
Yes, Professor HOLZ.
Yeah.
Yeah, sir, you please take this question.
But I'm surprised that a patient can leave the theater with such a result. You can check into.
You'll be surprised many times.
I think Professor HOLZ, you worked in India.
I worked in India, yes.
Yes, our bread and butter comes from the private practice. So this patient wanted to come back to Bombay. He had a connection within Bombay. He was told that you have a compartment syndrome, you got to be operated right away. So he was operated upon, and the second day the patient walked back. Anyway, that is apart from the social part of it, but now orthopedically. Second day he has come, after 2 days after surgery, he has come over. How do we proceed? Paul, you have any idea?
Well, I think I agree with Professor HOLZ. I don't exactly know what's happening yet, right? So that's why he's looking for that pre-op CT. So I would further define what's happening, and I think a CT is indicated. I mean, it looks to me like it was a fracture dislocation pattern that was missed. It seems like they went to the back, so I would get that CT and
here
deal with the metal subtraction and to understand the pattern better.
Here is the CT.
And the medial side is not fixed at all, I think. The part is not fixed at all.
Yep, here is the CT. Here is the CT. How do we proceed now? Any comments?
So I think you've got, sort of the similar kinds of things that both Professor HOLZ and myself showed earlier, where you've got that medial fragment, you've got the posteromedial fragment, and they sort of missed the boat. So I think unfortunately, you got to start from scratch here. So I would take everything out. You said it had fasciotomy wounds as well?
Sorry?
Did they have fasciotomy wounds as well?
Sales gimmick.
No, it was 2 days. It wasn't a compound fracture. It was a simple fracture which was operated upon.
Okay, but it wasn't a compartment syndrome.
No, there was no compartment syndrome.
So, I would probably go back. Hopefully the incisions are in a reasonable place. I'd have to evaluate that and decide if I can use the incisions that they have, but I'd probably do it in staged fashion. I'd probably, go in, I'd take everything out. I would get inflammatory markers, although it's hard to assess, so quickly after surgery. I'd get metabolic workup to make sure the vitamin D was good and there's no aberration. I would probably take everything out, clean it, do a biopsy, put it in a spanning frame to be able to evaluate the soft tissues, and then get a repeat CAT scan in the frame, just so I could really understand what was happening with the metal out and I would wait and make sure that there was no positive cultures before I went back in. There's a lot of places where they're not doing great work, also don't have great sterility. And if you redo this and there was something in there brewing, you'll be in trouble. So I take the cultures, irrigate it, clean everything out, get it back to an unfixed fracture, probably leave the fibular plate alone. If there's a palsy, I would probably, look for the nerve and make sure that it wasn't encased in anything or caught in anything, because that's another thing you can check. And then I'd get a repeat CAT scan and plan the definitive reconstruction for maybe a week or so later. There's no acuity to doing it. It's just as easy to do later.
Have you heard me presenting this in past?
No, but it sounds like we think alike, huh?
Yes. Anybody?
Yeah, I think
he's covered most of it.
That's more or less.
Yeah, this is exactly what I did. This is exactly what I did. I went around because I felt that with the hardware, the CT is not as very informative. So I removed everything because I didn't want to go ahead and operate upon the patient, which was operated upon in a place which I didn't trust. So exactly as Paul mentioned about it, I removed the whole hardware. I had to wash it out, cleaned it out, did the culture. Fortunately, the cultures were negative. 2 cultures were done. They were all negative. All the infection markers were negative. And so this is what was the post-operative X-ray, and this is what was the post-operative CT. This is the CT chap tells me that here is the one which is the common peroneal nerve is here, which has been pressed. This is the site of the previous cortical screw. This is where it has been pressed. And then here is the CT, which is done without the hardware. Exactly. That's the reason I asked you whether you have seen me presenting in past. So because exactly this is what we have done. So this is how the CT, which was done immediately afterwards, as soon as the hardware was removed. And here is the 2D, here is the 3D. This is how it was. And I waited for about a week or so till the time everything settled down and there was no infection, there was nothing there. Now you proceed further. How do we go ahead?
So what did you find with the common peroneal nerve?
Common peroneal nerve.
You said the CT showed something, but when you operated and exploded,
yeah, it was scarred. It was scarred. So I released it at the time when I opened up the plate. I released it for whatever it was worth. It wasn't cut, but it was scarred.
Okay, sure.
So now how do we proceed?
So
you have all these CTs.
Ajit, you take this call.
I'll take that. Yeah, I think so. I think we'll start. I would start from the back.
Yes.
The posterior condyle needs to be restored. I would get that in place, and then probably.
So when you say posterior, you mean posteromedial or the whole?
And as you can see over here, it was badly comminuted in between.
That's right.
So
it's the medial condyle that you need to get back.
Yeah. So I proceeded further. I went posteriorly. I fixed up posteriorly. I fixed up laterally, unequal plates, and it was whatever it was. There was a big gap here. There was a big gap here of the bones where I had put in the allograft. Obviously, I removed the plate. This is what it turned out to be. This is how the wound ultimately healed up. And here is the foot drop splint which was given. This is how it is now. This is 7 months. This is what is he has come after the 7 months. And you can see still this is what it is. And then further up, here is the foot drop. Here is the foot drop, and I did the tibialis posterior to anteriorly, and then here is obviously that foot drop part has been looked after well. So this is how it was. And now this is how 18 months. This is how the fracture is. You can see the screws have broken down. Now what? Now what?
So can we just, Dr. Tanna, go back to the immediate post-op X-ray? Because, I mean, I know this is a difficult situation, and suppose this had come primarily to you, would you be worried about that slight, there's still some subluxation if you look at the lateral view? Yeah? I know it's when you're doing a redo, it's always more,
You know, it was a badly comminuted lateral condyle.
yeah.
And also the medial condyle was comminuted.
So there's still some subluxation of the joint there, and that could be a problem.
Possibly.
Yeah. Paul, what would you say on that?
Sorry?
Or Dr. Professor Holz?
Yeah, Dr. TANNA, it is much better than before, but there is valgus.
And valgus, yeah.
And I think that the posteromedial part could have been restored a little bit better.
Okay.
So
posteromedial, I think it's lateral.
See, there is still an impaction on the lateral side.
Yeah, it's the lateral side.
Lateral side is the one which is, it was
still
all,
a problem.
it was badly affected.
Badly affected, yes, I know.
And once surgery's been done already, it's always more difficult, yeah.
And here I had put in the graft, and now this is 18 months. And as you can see, the screws have been broken down. The screws have broken. Now, how do we proceed now?
What are his symptoms, sir? Is he in pain? Is he unstable?
No pain.
No pain, no instability. So you wait.
Yeah,
self-dynamization.
That's right.
Self-dynamization.
This is exactly as I said. There was no pain, so I waited. This was a CT scan at that time. You can see after post-operatively what I had done. This is a CT scan. I feel the CT scan is fairly all right with the situations which was there. And this is 18 months, no pain. This is 25 months, the whole thing has held up. With the screws remained back and did nothing.
Yeah,
the only problem is that the valgus stress is now exactly on the worst part of the reconstructed joint. So at least I would advise to align the limb, to align it, in order not to have the whole stress on the worst part of the joint.
Here is the range of movement of the patient.
How old was the patient?
About 55, 60. I've spoken to him today. It is now about 2.5 years. Obviously, he is asymptomatic today. He is obviously perfectly all right. The foot drop and everything has been looked after. So at the moment, whatever is that lateral condyle, which is not regular, as you can see very well, it has not been very well corrected. So would you think you will have to go down now, probably in that person who is 55, to do some articular cartilage problem?
No. You see, if you say no pain, good function, there is no reason for surgery. There is no reason for surgery. So wait until it becomes worse. And
obviously,
in this case, later on, if he develops pain, I would go for a hemicompartmental replacement.
That's right. That's right.
But not now. Not now.
Here is the same thing which proves whatever is the radiology, if the patient has no pain, probably it doesn't need an action. And this is the fracture which is stabilizing, and it will heal up automatically. We have been talking about it again and again and again and again with innumerable, all fractures, not in this tibia fractures, in everywhere. The pain is a major criteria that the things are not doing well.
Sure.
Any other comments?
No,
Paul, anything else you want to like to comment on this?
No, I agree completely. I think that there's a lot of people in the U.S. and everywhere else that they want to operate, and I think you've got to define a clear advantage for the patient to be proposing surgery. If the patient's doing well, it doesn't seem to make a lot of sense to me to do surgery. So I agree with you. I would not do anything.
Thank you very much. Anybody, any questions? John?
No, I think the end result is a lot better than he would have been otherwise, so that's okay. If you hadn't done anything, you would have been a lot worse.
Sir, thank you very much. That was a wonderful case. Could I request Dr. Ajit to show his case, please?
John.
Hello.
Someone else is sharing the screen.
Yeah, Ajit, can you take up and show your case?
I think
the TANNA's. Okay.
Yeah. So
Let him share this.
right. So I think briefly, that's the history. It's a 20-year-old, came off his motorbike and he came pretty soon to the hospital. Otherwise, everything else is okay. I think we can go straight towards the definitive decision making, I guess. So I think both Prof. TORNETTA and Prof. HOLZ showed these examples. Any discussion on this from the panel? Any thought?
This is the opposite.
It's soft tissue and compartment syndrome.
All fine, all fine. That's fine.
Yeah.
And this is a total condylar fracture dislocation, but it's the opposite view. This is much less common.
Yeah, this is unusual. Yeah.
It's very unusual.
So I would do an early spanning fixator to get a provisional reduction and hold things in place.
Right.
And then
do you anticipate any problems with this type of fracture pattern, Prof. TORNETTA?
Yeah. I mean, you're through the notch in a bigger way, so you're likely to have some instability in the notch. But I would do the same thing. I would put it in a spanning frame, and then see how it lines up. Yeah, and now you've got to worry about the medial meniscus instead of the lateral side. But this is it's a different injury, and they tend to have a higher rate of compartment syndrome because the lateral soft tissues are much more tensed with this translation. And torn. So you really, once you put them in the frame, you've really got to watch them closely, either with continuous measurements or somebody with the skill to examine for compartment syndrome.
Okay, so essentially looking at this radiology and in the X-ray.
TORNETTA, there is a question from the audience, Ajit.
Yeah.
Supposing there is a question to Dr. TORNETTA from the audience.
Mm-hmm.
Now, supposing there is that this patient presents to you with all the facilities available for surgery, should you be worried about compartmental syndrome?
Why not?
Yes, absolutely.
Always.
I'm worried about, I mean, we've had, it's been a little bit of a run, but we've had 4 or 5 compartment syndromes in the last 3 weeks. And, the first one was in just a lateral split depression plateau in a muscular guy. So
because you're doing fasciotomy anyway, and that is the treatment for compartment.
I'm sorry, I missed that. What?
No, because supposing he comes to you immediately within first hour, first, whether will he develop a compartmental syndrome? And second, if yes, why? Because you are doing a fasciotomy anyway.
Oh, I see.
You're going to fix it and do a
You're
fasciotomy.
saying if he comes in with a compartment syndrome, would I fix it acutely?
No, not if he comes in. He comes to you within 1 hour of this problem.
So what you're trying to say is do a definitive internal fixation.
Yes, and do a fasciotomy.
I don't do definitive internal fixation for complicated injuries the day they show up in general.
Yeah.
So I like putting them in a frame and planning my case a little bit more definitively than that. And to me, there's no downside of that. And we watch them always for 48 hours for compartment syndrome when you put them in a frame, especially when you gain length. The other thing that's been reported with these is perineal palsy sometimes when you put them in a frame. So you've got to watch for the palsy as well as just the compartment syndrome. And that occurs more often when the lateral side is translated, but you can see that as well. So I wouldn't do definitive fixation. I would just put it in a frame. Now, if it was open, I might take the opportunity through an open wound to put a small antiglide plate on and hold things related and then definitively fix it later. But I don't want to do it right away.
Okay.
And if I can comment, Dr. Rajiv.
Yes, sir.
Your question says that if you do the open reduction and do the lateral about the plating and the medial plating, it will really look after the compartment syndrome. That's not true. That's not true.
You can get it later.
Yeah, you can get it later. So just because you put in the plate early, it doesn't look after the compartment syndrome.
Okay, sir. Okay, sir. That is a very good take-home message, sir. Thank you.
Right.
Yeah,
So,
and you may get away with it sometimes, but when it hits you, then it's going to really hit you bad.
And then you have to really release it all the way down.
Sir, so what is the ideal time to fix this then, according to you?
10 days, 10 days, 12 days.
For me, it's going to vary based on how it looks. So I don't like to do it the first day. I like to know that I don't have a compartment syndrome before I do it, because if this patient has a compartment syndrome, I'm going to do, I do a little bit different than most. I do pressure measurements in the operating room. Then I do the anterior, lateral, and superior posterior releases all through a lateral incision. If it's really a compartment syndrome, that puffs out quite a bit, and it's hard to get to the deep side from the lateral side. But what I do is then I re-stick the posterior medial compartment, and in most cases, the pressure is down from the skin incision and the rest of the releases. So I don't want to go medially unless I have to.
Yeah.
And then I like to have if it's a compartment syndrome present, I've done a fasciotomy. I do a very posterior fasciotomy incision. I stop a little bit short and run the fascia up because I don't want I don't want to ever use a fasciotomy incision or deep fascial incision from a fasciotomy for my definitive fixation. So I actually stage it until the fasciotomy wound is closed or skin grafted. Sometimes that's 3 weeks out, and I don't care. I'll wait. And I've never had an infection in one of those cases, and that is a known risk for infection working through the same location. So my fascial incision and my skin incision are always independent from my fasciotomy to my definitive reconstruction. Now, if there's no compartment syndrome, I'll do it whenever the skin looks good. Sometimes that's at 2 days. Sometimes they put the frame on, you watch the compartments, they never really swell up too much. You do them right away, no problem. So I'll do them anytime between the second day and 3 weeks out, depending on how the skin looks.
Yeah, I think the time varies with the soft tissue situation, and you have to wait for things to settle and then do it. But I think it's important in cases like this to get a provisional reduction in your frame, because if you don't reduce that, then your swelling is going to keep increasing even with the frame.
Right. Can I take it from there?
Yeah, sure.
Go ahead, Ajit. Yeah.
Can I make a submission here?
Yeah.
That we've had about a handful of cases like this, and in 2 or 3 of these situations, we just found it impossible to distract it in a fixator. We could not reduce this this sort of a fracture pattern in a fixator. Any thoughts on that?
Under anesthesia, are you talking?
Under anesthesia, sir, always.
So I would reduce it, make an effort to reduce it through some mini incisions or something like that. But I would want that reduced.
But what do you think is actually impeding the reduction?
So you may have to put a lever in and just put that condyle back in place. Yeah.
So it goes back to the question that the gentleman asked. If you're doing that, why not fix it? If you know or study this fracture pattern well, this is a lateral condyle. You're seeing an anterior split there with some depression there. There's nothing at the back, and the medial condyle is intact. And there's the CT. Can we study that CT a little bit? So is there any role for an early fixation in this?
I
Yes.
would put a plate in there, simple as that at that stage. Yeah.
Sorry?
I would be worried about putting a plate in there. I might put a mini screw to hold it reduced, the condyle reduced. Just put a couple of screws or wires across, but I wouldn't want to put a plate in at that time. I'd be worried about it. Unless I'm prepared to open the wound and leave it open. That's another option. But I mean, are you going to be doing this in the middle of the night?
No, not at all. Not at all. That's
so then that changes everything. Yeah. So then you're changing things according to whether it suits your time or not. Yeah.
Ajit, do I understand that even with the distractor, you tried to distract it out, you couldn't reduce it?
Not this particular.
It is very difficult to believe that.
No, it was not in this particular case. We've had a run of these 5 or 6 similar sort of where the femoral condyle impacts into the middle of the tibia.
Yeah.
You find it impossible to reduce it.
No, if you put a distractor on the table when you are trying to put in the X.
If they've come early, it's unusual, but if they come late, definitely that's
that's right. In an early case, you put a distractor and distract it out. Most of the time, that thing will really open it out.
Right. I think, Prof. Tanna, if you remember in the very first symposium that you attended in Bangalore, the AJIT symposium, we had a similar case, which we just found it impossible to reduce.
And I remember my comments were exactly the same.
Right.
Okay, let's get on. Carry on, Ajit.
Sir, so what is the take-home message at this level? Patient presenting to you on day 1 hour of surgery, 1 hour of accident, and that is the picture. How do you treat him? Do you treat him on an external fixator? Do you treat him on a calcaneal traction?
Scan plan, yes. Most
no, correct. Plan is all right. Scanning, okay. Is it an external fixator or is it a simple calcaneal traction? What it is?
So for something like this, it would mean an external fixator for sure. Yeah. And ideally the scan after you've put on the fixator.
On the fixator. Okay, fine. So this is a take-home message because the audience is asking that. Right. Okay. Carry on, Ajit.
Yeah. So as you can see,
you are asking Rajiv. In India wants to know what do you do.
He's the Arnab Goswami.
Is there any indication in some situations of plateau fractures where you would get an MRI along with a CT scan?
At this stage, no.
Right. After X-fix, you can't actually get an MRI scan. That's the problem.
Well, why do you MRI compatible?
As long as you don't use.
Yeah, there's MRI compatible frames that we use. You can
MRI compatible.
Right. I think I'll carry on for want of time, really. Yeah. So this is, in our experience, we found that these sort of fractures do take the meniscus along. It sort of herniates into this.
It is an absolutely known thing that this is the one when you open it up, you won't be able to do it because the meniscus is blocking it.
That's right.
So your MRI, if it is ACL is gone or PCL is gone, is not going to help you to really plan the surgery immediately.
No, this is basically for documentation. If we see this on the MRI, we don't try to put in a span or a fixator. Just go ahead and try and openly reduce it. And if there is any issues with the soft tissue, then do the bare minimum and come out like John said. Otherwise, go the whole hog and finish the whole thing at one go.
Okay.
I think it will be a dangerous message which you will be passing. That's a fracture like this, you can go ahead on day 1 and really proceed to fix it up as a definitive fixation.
But on the other side, sir, if you're not able to reduce to put an X-fix, that is equally dangerous as John said just now.
Yeah, so, okay, let's carry on.
Do you have a referee on this?
We could keep arguing on this one.
Exactly.
Right. No. Any views? I mean,
why I wanted to say is I think I didn't want you to go away without an opposition. So now you proceed whatever you want to proceed.
Right. Okay. So
we all know what.
That's the meniscus inside there. You can see the condyle is bare on that side. And I don't know whether that is actually part of the medial collateral ligament also going into the thing. I'm not sure. I don't have the other cuts for you, but there is a whole lot of soft tissue which is actually impeding reduction in many of these cases.
Sure.
And you see the meniscus, we incised that at the front there and lifted it off right round. And then we were able to reduce it. It becomes a very simple matter there, right? And then that's not a very comminuted fracture. It's a straightforward, huge chunk. So you can do a good job there. There's no issues. And since there was an anterior comminution, anterior part, we just put in this sort of a rim plate just to hold that in place. Underneath the patellar tendon, just pushed it in. And then for the lateral condyle, put in a plate like so. Any comments at this stage?
Yeah, I mean, if it's done well.
No, done well, you have to see the functional outcome. At this stage,
it's done well. I mean, it's the surgery's been done well. I don't know about the patient.
No, I mean, that's not a problem. So essentially, this was what we wanted to highlight. The meniscus actually gets driven into the thing, and it's almost like an inverted labrum in your acetabular fractures that you can sometimes not reduce the hip there, a dislocated hip. And once you release that, then that's a much easier job. So it's not a very comminuted fracture where you have to think of a posterior approach or whatever. So we went ahead and did the whole thing right at the outset. Sorry, that's the 4 months follow-up.
Yeah.
Right.
Very good.
Thank you, Ajit.
Thank you.
That was a very good case. Sir, we have a curfew here from 9 o'clock. So we have to leave the place. So Dr. John's case, we will not be able to take.
No problem.
Presentation today. Apologies, Dr. John, from our side, because we have to leave at 9 o'clock.
Okay,
because
no
of
problem.
curfew.
Are you at your home or you are somewhere away?
No, sir, we are away.
Oh, how can it be?
That's what. We are a little, we have got a special provision for us.
But surprising, we are all at home.
Correct, but we are in a hotel, sir.
Everybody else is at home. Okay.
So we are able to coordinate it very nicely. That is why.
Okay, great.
Okay,
Not a problem at all. Don't worry.
We took special permission for this event.
Yes, very good.
So we thank you one and all for an excellent cooperation. And just bear with us for 2 minutes. We have Dr. Ketan Kulkarni. He's from MQR, and that is the company that has sponsored this event, and he would like to say a few words. Dr. Ketan, welcome.
Thank you, sir. Thank you, sir. I am Dr. Ketan Kulkarni from Medical Service Team at MQR Pharmaceuticals Limited in Pune. Good evening, doctors. This master class on proximal tibia fractures was very comprehensive, and we have received many appreciating comments from the delegates. Almost 600 plus participants attended this program across the world, and I extend my deep gratitude towards the esteemed faculty for this program who made this very interesting scientific session. So I like to thank Professor Dr. ULRICH HOLZ, Dr. James STANNARD, Dr. Paul TORNETTA, Dr. TANNA, Dr. MUKHOPADHYAYA, Dr. AJIT KUMAR. And I also like to thank our moderators, Dr. Rajiv Naik and Dr. Ram Subba Reddy for bringing out the clinical pearls. A special thanks to Bangalore Orthopaedic Society members, Dr. Uday Kumar, Dr. Madan Ballal, Dr. Arvind Parthasarthi for designing this magnificent program. From MQR side, we will always be happy to collaborate with these activities. We also will like to thank all the doctors basically for helping the patients during this COVID situation. So thank you very much for this illuminating webinar. Thank you, all of you. Yeah, so Mr. Satish.
Okay.
Video presentation. 2 minutes.
Yeah, we'll play a small video which is a gratitude for all of from us for helping all the patients during this COVID pandemic. Thank you.
Please.
जात धर्म क्या सभी का ख्याल रखते हो, बस लक्ष्य है सेवा, सेवा से कभी ना थकते हो, नहीं जान की परवाह, निकले हो जान बचाने को, तुम रोक ही लोगे आंधी जो है आने को। शुक्रिया भारत के योद्धाओं, MQR करे सलाम आपको। शुक्रिया भारत के योद्धाओं, MQR करे सलाम आपको। कैसी ये जंग है पड़ी मौत सांसों के पीछे, बने तुम जो मसीहा जगी जिंदगी में उम्मीदें, वहाँ वीर खड़े हैं उन सरहदों की रक्षा में, यहाँ आप डटे हैं इंडिया की सुरक्षा में। शुक्रिया भारत के योद्धाओं, एम्प्योर करे सलाम आपको। शुक्रिया भारत के योद्धाओं, एम्प्योर करे सलाम आपको। एम्प्योर करे सलाम आपको।
Thank you.
Yeah, thank you.
Kindly bless us.
Thanks.
Sir, I'm ending now.
Okay.
Yeah, thank you.
Great seeing
Thanks
everybody.
very much, sir. And we hope to see you all again, sir. Please accept our invitation.
Thank you.
Bye. Bye, Dr.
Yeah,
Tanna,
bye.
Paul, Rajiv,
Bye.
Ajit,
Bye.
everyone. Yeah. Okay. Bye.
Thank you.
Bye,
Stay
Uday.
safe.
Bye.
Take care.
Yeah. Bye, sir. Thank you.